Welcome everybody to our annual BrainSTEPS team member capacity building training. This is Brenda and it is May 28th, 2020. Thank you so much for joining us today in these unprecedented times. Excuse me. I'm glad that we could all still get together to learn about brain injury. There are some details for today. So there will be a 15-minute break between each webinar. So there are 3 webinars today, which means we are going to have 2 15-minute breaks. You must fill out the evaluation online from Patton within the coming week if you need professional credits. You must attend all 3 webinars today. Partial credits will not be provided. And this training serves as our annual capacity building training for team members. Therefore, all 3 webinars are required. For those of your team members who may not have been able to be here today, this is being recorded and we will have a post-test that team members can take so that they get credit for their annual BrainSTEPS training. Now also, we will take questions at the end of all 3 separate presentations today. If you have questions, please go to the widget bar on your Zoom menu, and there is a question and answer, Q&A. Please put all of your questions in the Q&A. Don't put them in the chat because questions tend to get lost in the chat feature. Instead, post them in the Q&A, and then our presenters, we will go through the questions at the end with our presenters. So for our first presentation today, Monica, if you want to go ahead and share your screen, we have Monica Vaquero. Monica is the Director of Programs for the Brain Injury Association of Pennsylvania. In this role, she provides oversight and direction to multiple programs, including the Brain Injury Resource Line, Neuro Resource Facilitation for youth with brain injury in juvenile detention, and the BrainSTEPS program. Ms. Vaquero has 29 years of experience working with individuals with brain injury and their families as a clinician in medical rehabilitation. In addition to her role with the Brain Injury Association of Pennsylvania, she is a research associate at Moss Rehabilitation Research Institute, with a particular interest in clinical trials of interventions for common effects of brain injury, including anger management, depression, and goal setting.
So Brenda, did you want me to start?
Yes.
Okay, so thank you everyone for having me here today. You know, this first topic is something that we're hearing more and more about all of the time. While the epidemic of opioid misuse and resulting overdoses and everything that comes with that is clear, we're getting more and more information about how it overlaps with brain injury and will affect maybe some of the work that you do. So just to let you know, the work on developing this content on brain injury and opioids is funded through a state implementation grant, a federal grant through the Administration of Community Living, which was obtained by the Pennsylvania Department of Health. And the Pennsylvania Department of Health contracted with the Brain Injury Association of Pennsylvania to develop and implement the trainings. So the opioid epidemic, as I'm sure you're aware, has just exploded over the past several years. And the misuse of opioids, ranging from prescription painkillers to heroin and to synthetic opioids, has just become epidemic. And this chart that you're seeing here is showing deaths per 100,000 people in the population. But a few other facts, you know, as of 2015, the number of deaths from drug overdoses has become greater than the number of fatalities due to motor vehicle accidents for the first time. And since 1999, nearly 200,000 people have died from an overdose from prescription drugs. What we're seeing now is that as there are more regulations to control the prescription of opioids to treat various conditions, since that is being regulated in a much better way, what we're seeing now is an increase in the amount of heroin use and the synthetic opioids. So We're estimating that 2.5 million Americans are addicted to opioids and heroin. This is coming from the National Institute of Drug Addiction. It's an estimate that they've come up with. And so, we know that people become dependent very quickly. This study I'm showing you says after 1 week of regular use, there's dependency being seen. And a lot of people who are taking an opioid painkiller that was prescribed don't even realize that it's an opioid. And I'm sorry, the reference is not there. I'm going to need to add that. So how does this relate to brain injury, and why is understanding opioids and misuse so important? But just looking at substance abuse in general, there's a high proportion of people in brain injury rehab who have a history of substance abuse before their brain injury, 67%. And then we have another 20% who didn't have substance abuse issues before their injury and developed them after their brain injury. And flipping the coin for a minute and looking at the substance abuse side, we had been looking at the brain injury rehab side, now looking at the substance disorder rehab, we see that 50% of people in substance abuse disorder rehab have evidence of an acquired brain injury. So there are a lot of people out there getting treatment that may or may not be accommodating their brain injury. And something that is becoming increasingly, it's not that it's new information, but that the world is becoming more aware of, is that people who survive an opioid dose may suffer an anoxic brain injury, and probably do, and we'll get into how and why that happens. So the goal of some of this work from the Brain Injury Association point of view, in collaboration with the Department of Health, is to educate substance abuse providers on the fact that they have individuals with brain injury in their treatment that they might not be aware of, how to identify them, how to appropriately accommodate them. So back to the American Society of Addiction Medicine. We are operating under 3 validated premises when we do this work. One is that addiction is a primary chronic disease of the brain, and specifically the brain reward, motivation, memory, and all the related circuitry, which I'll show you in a little bit. And that drug addiction is a compulsive drive to take the drug without regard to the consequences. Unrelated to brain injury, that's just what drug addiction is and how it manifests. But what is relevant for us as people who work in the field of brain injury is that there's an interaction between the brain's opioid and dopamine systems in this process, the process of reinforcing and addictive effects. So we come to this term, the toxic brain. And the term was developed by the Brain Injury Association of America and the National Institute on Drug Abuse. And so the first thing I wanted to point out to you in thinking about opioid use and brain injury is this video. It's actually a documentary called Roads to Recovery, Overuse and Brain Injury. I'm not going to show it because it's like 28 minutes long, but I wanted you to have access to it. It's a really wonderfully instructive video that you might find useful, and I can certainly get some permissions for you if you need them to excerpt from it and to put it into some of your trainings. We have gotten permission from the director at PBS in New Hampshire to do that, and we include some clips in our longer course on brain injury, which we've developed, an 8-hour course for substance abuse providers. But this is something that looks at the effect of opioids and overdose causing anoxic brain injury, which seems pretty obvious to us in our field, but is not at all obvious to the medical field at large. That it's not just about saving somebody with a rescue drug, it's about what happens afterwards if someone has overdosed and what the effects are. It tells the story of what happens to the brain during and after an event, and it features one family who has a loved one with a severe brain injury as a result of an anoxic injury post rescue from an overdose, and then a couple of other people who have also had anoxic brain injuries with lesser but certainly substantial effects. And it talks about how treatment is affected. You see a picture here, you may recognize Dr. John Corrigan from the Ohio State University. He's a preeminent scholar in brain injury and international presenter, and he's featured in this video along with the families. So I've provided the link here. You can also Google it just by Roads to Recovery, Overdose and Brain Injury, and it's available to the public. So back to just opioids in the brain. So we know that drug addiction is a chronic disorder and it's a relapsing disorder. But why is it considered a brain disorder? Well, it is because, you know, it involves changes in the brain circuits. It affects the integrity of neurochemicals, the cortical tissue, so it affects cortical functioning. You see cognitive changes because of the actions of opioids on the brain, and it causes a toxic brain injury. So, and having a brain injury is also a risk factor for addiction and for difficulty responding to treatment. So the big picture here is that addiction is a behavior that originates from our brains, and it interferes with the function of the brain, and that's why it's considered a brain disorder. So how do opioids act on the brain? Well, they are depressants. They're central nervous system depressants. They inhibit the actions and the functions of the central nervous system. They slow down body functions. They slow down heart rate. They slow down breathing. And that can lead to loss of consciousness, coma, or death. You know, what happens is the body really just forgets to breathe, and the respiration becomes so slowed that there is lack of oxygen or insufficient oxygen to the brain. So toxic brain injury, which we talked about a little bit before, the idea of a toxic brain, it occurs because of prolonged substance misuse and non-fatal overdose. So we're finding that there is both hypoxic and anoxic injury that can occur. Hypoxic, as you know, is when the brain doesn't receive enough oxygen. So there is some literature suggesting that if people have enough hypoxic events, periods of time where they're not getting sufficient oxygen to the brain because of the effect, the depressant effect on the central nervous system, that you can get hypoxic brain injury. And then in the case of a non-fatal drug overdose, there is likely to be a period of time when the brain doesn't receive any oxygen, and then you have an anoxic brain injury. It can be very severe, as you will see in the video, and it can be less severe. There's a range of effects, just as you would see in any brain injury. So what causes it? You know, it's caused by the disruption of nutrients in the brain, direct damage, death of brain cells, you know, disruption of the neurotransmitters, alteration to the brain chemicals, and a deprivation of oxygen to the brain. So let's take a look a little bit at this chart. We're not going to go through it in any detail, and I know it's not large. I think you still should be able to read it. But, you know, we know that neurons communicate, that neurons, the brain cells, communicate through these neurotransmitters. They send chemical messages over a process called synaptic transmission. So all of these neurotransmitters are operating within the brain at all times. But let's take a look at this third line, this dopamine line. This is the neurotransmitter most prominently, I would say, impacted with opioid use and misuse. Because the dopamine system, one of its functions is the reward pathways, which is, you know, part of the addiction process. There are also functions of cognition and voluntary motion. You know, you see it in the hypothalamus. We'll talk later about how it's also in the frontal lobe. And imbalances in dopamine can cause all sorts of significant effects on the brain. So let's take a look at the dopaminergic regions. I'm not going to get into this in great detail, but it does illustrate for you, looking at a cross-section of the brain, where the dopamine systems are, where the projections go, where the receptors are. And you can see there are two main areas of the brain implicated. One is the prefrontal cortex of the frontal lobe, which I'm sure you know quite a lot about, but you can imagine as those functions are impacted, what the result would be in a person's everyday function. And then the deeper regions, the limbic system, which really has, you know, more responsibility in the areas of emotional and physical memory of that experience. So these two areas are both implicated. And, you know, it's about a reward system. Rewards feel good. I mean, if you look at this graph on the side, two main reward systems in our brain, food and sex, you can see that the dopamine levels are elevated when the reward system is in action. So, big picture here with this opioids and dopamine system, the big picture here is that, in this neurobiology of dependence, is that there is disruption in the frontal lobe, the frontal cortical response, the cortical areas of the brain, and the limbic area. And on the left, if you follow the arrow to the disruption of the frontal cortex, you know what the frontal cortex does. It has behavioral control mechanisms in there. So as this circuitry is impacting, you're going to see changes in the person's goal setting, in their motivation, in their planning, in their impulse inhibition. And on the limbic system side, you're going to see disruption causing anxiety, urgency, a negative affect, the craving, and the impulsiveness. And these two interact, causing what we talk about as the toxic brain. So, our brains are wired such that, pleasurable activities are things that we want to repeat. It's just a natural wiring of our brain, and dopamine is central to that. So what happens is dopamine kind of lights up the system. There's a burst of dopamine because of this change in the activity of the neurotransmitters. There's a burst that says something is happening. I need to remember it. That's how we make a habit. And then it makes it easier and easier to repeat that activity without thinking. And so these surges in dopamine teach the brain to seek the drug, and at the expense of any other goals. It becomes what the brain is after. And so in response to drug-related dopamine dumps, our brains we have fewer neurotransmitters that are produced in the reward circuit, reduced pleasure and naturally occurring activities. People feel, when they're not using the drug, obviously, they feel flat, unmotivated, depressed. That's cortical depression. And in order to experience that pleasure and get out of that cortical depression, there's requires increased dosages of the drugs and increased risk. So, opioids, you're characterized by just a loss of behavior. Deficits in inhibitory control. And listen to these overlap with what you see in people with brain injury who have frontal lobe impairments. Now you have this additional layer of deficits in inhibitory control and decision-making and regulation that happen because of the role of the frontal lobe in the toxic brain. So what does this mean for substance abuse treatment? You think about a person's need to be successful in addressing their substance abuse. And I realize that we don't have any opportunity for this to be interactive, but at this point, I would normally want to ask you the question, have you known anyone with a brain injury who is in substance abuse treatment? Knowing that the substance abuse treatment system is really not set up to accommodate issues related to brain injury. So just think for a minute if you know of anyone in that system. I can tell you that in order to be successful in a substance abuse program, the person has to have cognitive skills and abilities, and they can be compromised by the brain injury. So a person may not be able to use the treatment that they're provided because of their cognitive impairments from the brain injury. And so what becomes relevant here is how we can adapt substance abuse treatment to facilitate success for people with brain injury. And this may be a role that you take on as you help systems to develop interventions, whether you're working with youth who are in substance abuse treatment, I don't know, but if you are, there are certainly some things that they need to know in order for the individual to be able to benefit. So you think about this, conventional treatments are typically things like treatment groups or, counseling that requires some cognitive skills. If you've worked with any youth who are in counseling, you may have seen that even in one-on-one counseling, it requires some cognitive skills to benefit from it. A person needs to be able to remember from session to session. They need to be able to take the information that was talked about in a session and really abstract from that what applies to them. And then in their everyday life, they need to be able to use that information to change their behavior. That's very complex. And that's something that individuals with executive function struggle with. And you're working with youth, which, you know, the issues of development are an additional layer, and frontal lobes are still developing well after your work with youth. I can tell you from the adult literature and my clinical experience that this continues to be a problem. That, you know, even after we get to the period of time where we think frontal lobes are developed and people can make better decisions, if they have a brain injury and have impairment to the frontal lobe, we see lots of difficulties in benefiting from treatment. There's a greater likelihood of co-occurring behavioral issues in this program. I've certainly seen people in group treatments for substance abuse that just are seen as inappropriate by those who are providing the treatment. Either they don't contribute, kind of just sort of passively sit there, or with emotional dysregulation, perhaps are disinhibited, share more than they should, sometimes monopolize the conversation. We see a lot of people get literally kicked out of groups because they're not able to maintain appropriate group behavior. And then think about also, even with people when they make improvements in substance abuse treatment, maintenance is really difficult in the best case scenario. But for somebody with a brain injury, it can be very difficult to maintain improvements unless there's continued structure and support. It's not usually the case that a person can finish substance abuse treatment, even if it goes on for a while, maintain some level of improvement, and then go out into the world and not have the brain injury affect their ability to remain sober. I mean, thinking about goal setting and goal-directed behavior, if a person has impairments to their frontal lobes of their brain, sometimes behavior in those cases is not really directed by a goal. It could be directed by the environment. A person with brain injury who goes out into the community intending to go to the store to purchase something, sees something else along the way or another person along the way and gets distracted from their goal and does something else and are more responsive to the environment than directed by their own goals. And this can definitely impact maintaining improvements from substance abuse treatment and remaining sober. The environment can dictate what a person does more than their own goals. And so ongoing structure and support on an individualized basis is really critical to being able to maintain improvements. So let's think for a little bit about what it would be like for a person with cognitive impairment to be involved in substance abuse treatment. So if a person is in a group and they have cognitive impairments, let's think about what could get in the way. First of all, the ability to attend for a period of time. I've certainly seen substance abuse group treatments that are an hour, that are 2 hours, and sometimes a person with a brain injury can't attend for that long. In fact, frequently can't attend for that long. And even if they stay in the room and sit there for that long, that doesn't mean they're able to benefit because of issues with sustained attention. Focusing attention on the content is one thing, but being able to sustain it over a period of time and maintain distraction-free attention so that they can benefit is really impacted by brain injury. And then memory. We all know that one of the hallmarks of brain injury is memory. Memory complaints continue long post-brain injury as one of the things that is the most challenging. So if they're in a group treatment or even an individualized treatment, as I mentioned before, there is some need to rely on what happened in the last session. Examples were brought up, didactic material was presented, and now you're moving on and you're building upon that. And if a person doesn't remember what happened in the last session, they're less likely to be able to benefit from it. And then the ability to abstract, and this is something that I'm sure that you see all the time, to be able to abstract from what you hear. Someone tells their story, they give an example of a challenge they face, they talk about solutions to that challenge. For the person with brain injury to be able to understand how that applies to them requires abstraction, which is frequently impaired after brain injury. Some other cognitive issues that can interfere with treatment. Sleep, which may sound very basic, But in order to really be able to do the best that you can, to be able to attend, to understand, to comprehend, and to, apply what you've heard and what you've learned, you have to have a rested brain. And sleep impairments after brain injury are very common, and they can extend for a long period of time. It's not a problem that's easily solved. Certainly there are things that can be done to improve sleep, but it impacts attention and endurance, and it can impact the ability to benefit from treatment as a result. And here's something that we don't always think about, is the ability to prospectively remember an appointment. So, much of substance abuse treatment happens on an outpatient basis. People are in their homes or in whatever living situation they're in, and they have to get to a group or get to an appointment with a counselor. And even though the person may remember that they have that appointment, they remember Tuesday at 2, I'm supposed to meet with my counselor. And if you ask them that, they can tell you that. That doesn't mean that Tuesday, it pops up in their memory and they do what they need to do to get there. Prospectively remembering to do something that you intend to do is a frontally based function. So even remembering to go on the day that you need to go is an issue, but then planning to get to that appointment. Cognitive impairments can get in the way of planning to go to an appointment. I've worked with people where I see this very frequently, where someone says, yes, I have an appointment on Tuesday at 2. Yeah, it's 1:45, I better get there. Well, what they don't think about is if they're taking a bus, that bus doesn't come at 1:45. It might come on the hour, or it might come on the half hour. Which one do they have to take? And maybe the ride is longer than 15 minutes. And maybe the ride could get them there just in time, but they still have to find the meeting. So all of the planning that's involved in traveling to an appointment, deciding what mode of transportation, knowing what time you need to get up in order to be ready to get out the door to that appointment is impacted by brain injury. And I can't stress this enough. I see people regularly discontinued in treatment because of missing appointments. It's very common, and it can appear to be a choice, because when you call that person and say, hey, you had an appointment today, they said, oh yeah, 2:00, this such and such address. They have all the information, and you're thinking, well, you didn't forget. But there's more to remembering than just the semantic piece. There is the prospective piece. There's the piece of it popping up in your memory when you need to, and then also doing all the planning that's required to get there on time. So that's for some group sessions. What about individual sessions? When a person is working one-on-one with a therapist, there are some really good treatments out there. In fact, Brenda, if you can let me know later if you're interested, there is a system called SUBI, the Substance Abuse and Brain Injury Manual, which is a way of providing substance abuse treatment to individuals with brain injury, which can be pretty effective. But typically, even if there are one-to-one sessions with a person, we know that people with brain injury don't necessarily have awareness of their injury. I don't know to the degree to which you see that in your setting, but we certainly know that sometimes people will report that they're doing fine and they believe it. It's not a misrepresentation of what they're feeling, but they're just not aware of the ways in which they're not doing fine. And so they might not accurately report how they're doing, and the counselor's relying on their self-report. Part of that is about awareness, but part of it is also just about the ability to remember. So if you're meeting with a counselor on Tuesday and you had issues on the weekend and you meet once a week, a person might not be able to reflect back and remember that. There's some new and exciting technologies out there that can work around that. There is it's momentary assessment, EMA, ecological momentary assessment, that can be done through some apps where a person is prompted on a predetermined basis to report how they're doing at that moment. And that's another way for therapists to get data about how a person is doing. I don't know how frequently it's being used, but it's an emerging technology that would be helpful. The person with a brain injury might not follow through with the recommendations, even if they've agreed upon it, because they might not remember. Or they might remember and then just don't initiate the follow through, as you, I'm sure, have seen with your work with children with brain injury. They could have some difficulty developing insight, and sometimes substance abuse training is really about motivational interviewing, where somebody really starts to learn about, what changes they might need to make. And, you have to have some insight into your behavior to benefit from that. So they may not recognize their need for treatment and they're going just because they're being compliant. And as we said before, not remembering from session to session what the content was so that it can be built upon. So in groups, people with brain injury may have trouble understanding the content or processing it quickly enough. And this has, direct correlation with the kind of work you do with kids in school. It's very much like a classroom environment. And as you're developing strategies for teachers to use to help the students with brain injury with their comprehension or with, the processing speed issues, this is something that needs to happen with counselors and substance abuse treatment as well. And this is, if you're working with youth who are in treatment, I would highly recommend that you consider some of those same interventions for a substance abuse counselor as well as you do in the classroom. Sometimes we think this isn't our area of expertise, this is their area of expertise, but it really is a braided treatment, the substance abuse treatment and the brain injury treatment. And the person with brain injury may have limited ability to recognize how this applies to them, as we said before. They may over or under contribute in groups. They might repeat themselves because of perseveration or because they don't remember what they said before. And they might not be able to initiate or complete homework tasks and come to the group session unprepared. And how do you think that's interpreted? It's interpreted as non-compliance or a behavioral issue, when in reality, it's the cognitive issues from the brain injury that are making it difficult for that person to behave appropriately in the group and follow through. So I have some references here, some selected references. I have, I think, just a page of them. And so, you might want to do some further reading on this topic. I would highly recommend watching the New Hampshire Public Broadcasting Roads to Recovery. And certainly for any further information, you can call the Brain Injury Resource Line. You can go to our website, Department of Health's website. I have a couple phone numbers for you, but also Brenda can share my direct contact email and phone number, and I would be glad to assist in any way if you have a student with substance abuse that you're trying to accommodate for, either in the classroom or helping their treatment specialist to be able to appropriately provide substance abuse treatment. So Brenda, were there questions that came in?
Well, let's open it up for questions. So does anyone have any questions about anything Monica talked about? Have you worked with any students who have experienced this? You can share, de-identified information with us about how you supported the student.
Yeah, and related to the kind of the bottom line of all of this is that people with brain injury are more vulnerable to addiction, and that opioid addiction also causes brain injury. It's both sides, and that, the ability to respond to treatment is affected by the brain injury, and to maintain is affected by the brain injury.
We do have a few questions. So first, someone asked, what was the new technology called? Ecological what?
Ecological momentary assessment, EMA. I've used this in some research trials. I don't know the degree to which it's used clinically. I've used a program called, I think it's called Real Life. I could get the reference for you. But what it does, and there are some studies that show that it's being used in some mental health treatment in particular. So what it does is uses SMS, messaging through a phone to ping someone and prompt them to answer questions that you identify. So in work I've been using it with, we're trying to see if behavioral activation improves depression in people with brain injury, because there's a lot of research that shows that behavioral activation is a very effective treatment, meaning the more you do of activities that give you pleasure, satisfaction, or enjoyment, the more your mood is likely to improve. So we want to know what people are doing at a given moment in time and how they're feeling about that. So We ping them and it asks how they're feeling, and it's not open-ended. You give an emotion and they rate it, how they're feeling. And then after they do that, you ask them where they are, who they're with, what they're doing. And so the therapist can later use those data, because people can be pinged as many times a day or as many days a week as you choose. And then you have a lot of data that shows what people are doing and how they're feeling. So this could be adapted to any treatment. I've seen it be adapted in treating mental health, in getting people to report symptoms that they're having on a regular basis, rather than just at the appointment that maybe is once a week or twice a month, giving some sort of aggregate interpretation, which may not be accurate.
Okay, we have a couple other questions. So one person said, I'm thinking of my sister who's a drug and alcohol counselor. Do you provide any in-depth training for counselors?
Yes, so that's the whole purpose of this project. I've just given you a smattering of it, but the purpose of this project that I told you is funded through a federal grant that the Department of Health obtained is to educate substance abuse providers. So we've developed a course, actually. It's a course that consists of 4 classes. Each class is 2 hours, goes into great detail. More of the neurobiology and the neurochemistry that I told you about, but also some basic brain injury education, because substance abuse counselors don't get that, and in more depth about what kind of interventions they might consider and how to braid brain injury treatment and substance abuse treatment. So it's an 8-hour course. We are able to deliver that free of charge to substance abuse providers who are interested. We like to work with a system rather than an individual, because if we pull together people who work in one system, it's more likely to cause some system change. Our course even teaches them how to screen for brain injury in their system. So absolutely, this is the intention. I mean, we have funding for at least a year to provide 6 to 12 of these courses. So if you know of anyone who works for a system that might be interested in this training, certainly let me know. Our goal was to do this live because our intention is to develop a relationship with that system and be able to provide technical assistance in an ongoing way. But in the environment of COVID-19, we're transferring it or converting it to a virtual training, which we'll do until we can do live visits. So 8 hours of training divided into 4 classes. We like to do them 1 class at a time, but we can accommodate whatever the agency is looking for. In fact, the next 2 that are scheduled, we're doing a 4-hour and then with a break, an hour break in between, and then 4 hours the next day, so we can individualize.
So they would just contact you, Monica?
Just contact me.
Okay.
Yeah.
And Monica's contact information is on the, I think it's on the first slide. If not, I'll give it to you. Okay.
Yeah, I'm organizing the trainings, and we have a number of trainers across the state. We have a neuropsychologist in Pittsburgh. We have a few neuropsychologists in the Southeast. And as we get trainings in other areas of the state, we're going to be exploring finding additional trainers.
Okay. Another question, do you think that all people who have overdosed on opioids and have been resuscitated have some brain injury, even if it may not be readily apparent?
Well, that's an opinion question. I have to think about it logically. I can't imagine that someone who has overdosed to the point where they have to be rescued hasn't had a period of time where their brain was not getting oxygen. They're unconscious, right, most of the time. So, there is a white paper that was developed by the Brain Injury Association of America on this. Brenda, I can send that to you, on non-fatal drug overdose. But yeah, I mean, I can't imagine, logically speaking, I can't imagine that it's not happening. From my clinical experience, I've certainly seen many people in inpatient rehabilitation with severe brain injury as a result of overdose and rescue. And you'll see it in this video, this documentary presented by PBS of New Hampshire. They go through it in great detail, what actually happens, but not at the neurobiologic level or neurochemical level so much like we've talked about, but just kind of, they talk about with EMS workers and what they're finding. An interesting finding that I didn't know is that, when a rescue drug is used to bring somebody back, and what it essentially does is trigger breathing, depending on how much substance is in the system, it may not continue to work. Like a person could overdose again after 20 or 30 minutes if it's still in the system and need to be rescued again. That was something I wasn't aware of.
Okay, a few more questions. And then I'm getting some comments about if we could show the video since we're done so early today.
Well, let me see if I can do that.
Okay, and while you're doing that, another question is there any research on effectiveness of 12-step groups and traumatic brain injury?
Not research, certainly, that I've seen, but you know, when you think of what happens in a typical AA or NA meeting, it's a group treatment. It requires, you know, listening to examples and applying it to your life. I've certainly known of people with brain injury who the structure of that really helps them. Whether there's any research on whether or not they maintain sobriety, I don't know.
Okay. Another question. Do you know of any trials in which they successfully wean people off of the drugs and increase dopamine through positive lifestyle activities? Or do you find that brain injured individuals are not that resilient?
Can you repeat that, Brenda? I don't think I caught the beginning of it.
Okay. Do you know of trials in which they successfully wean people off of the drugs and increase dopamine through positive lifestyle activities? Or do you find that individuals with brain injury are not that resilient?
Yeah, I mean, I have certainly not seen any trials of things like that. I just don't think there's any research on that. But, you know, certainly getting someone off the drug in a detox program, usually the next step is individualized treatment. You know, whether they include behavioral activation, which I talked about, which is those pleasurable activities that can lighten your mood. I don't know that that's going to impact sobriety. There's nothing. No. Okay. There aren't even trials that show yet. We're working on a trial now that behavioral activation is effective with brain injury. It's been proven effective in other populations.
Okay.
So Brenda, I don't quite know how to do this. Maybe your tech person can help. I have the video loaded, but it's a video that is on the internet.
Yeah.
You think I can share my screen and we can see this?
Yes, when you go to share your screen, in the bottom corner is going to be a checkbox that says share my audio. Make sure you check that before you send your screen over.
So I'm seeing under share screen, I'm seeing share computer sound. Is that what you mean?
Go.
And optimize screen share for video clip?
Sure.
Okay.
Monica, before you start it, do you know of any resources for caregivers of teens who have overdosed and now have an anoxic brain injury?
I don't. I mean, you know, the best resource I know of are support groups for parents, where you might meet a parent who has that issue that could share with you. What I would say though is, you know, we're always happy to try to develop groups. So if as a BrainSTEPS program, you identify some parents with teens who would like to have a support group, we're happy to help with that.
And then lastly, someone works with parents of preschool age children, and she's wondering, so parents of preschool age children who have substance abuse issues. So the parents have substance abuse issues, I guess. Are there resources for parenting or to help parents gain awareness and support? Oh, we can't hear you. Okay.
Sorry, can you hear me now?
Yeah.
I'm getting some weird messages as I try to load this video. You know, the only resources to support parents and parenting would come from, you know, a system that I'm not really all that. I mean, Brenda, I think you would probably know more about that than I would. I don't know anything specific in the brain injury community to support parents who are addicted. I think that would probably be in the substance abuse community.
Right.
I can only imagine that they exist, but it's not my area of expertise.
Okay.
Do you know of anything, Brenda?
I don't, because this is a new area for me.
Yeah. So how about you and I do some research and see if we can find anything?
Yeah, definitely.
All right, let me see if this works.
Major funding for the production of Roads to Recovery 3 has been provided by Dartmouth Hitchcock Health. Additional funding provided by the Brain Injury Association of New Hampshire.
It's exciting. We're unsure of what calls we're going to be responding to, and the fact that you can make a difference in somebody's life at the end of the day is a big, reward.
Tracy Powers is on the move. She's a paramedic supervisor in Manchester, New Hampshire. Her day begins with the sound of an alarm. She and her crew pack up and respond to a call. They find an elderly woman who fell in her home, but she'll be okay. By the end of the day, however, Tracy will likely save a life.
Overdoses have increased greatly since I started. This was not something that we've seen. They were here and there, but now we go to multiple during shifts. We might have one a week, and now we could have up to 3 or 4 a day.
First responders carry plenty of naloxone. Commonly known by the brand name Narcan, it's a nasal spray that is used to reverse the effects of an opioid overdose. And it works. But as lives are spared, a hidden problem emerges.
We were dispatched for a possible overdose seizure. When we arrived on scene, Manchester Fire was already on scene administering Narcan to the patients. There was drug paraphernalia in the room. When we got to her, the Narcan was given and the patient immediately started to seize, meaning that there's probably an amphetamine on board. We see the side effects of a seizure from a spice overdose, but we're also wondering if the fact that she was hypoxic for a period of time, lack of oxygen to the brain, that may have caused this seizure. The signs and symptoms, what we were seeing, weren't good, and it appeared to be possible brain injury due to hypoxia.
New Hampshire is not alone in its struggle with substance use disorder. In 2018, nearly 70,000 Americans died of an overdose. There is, however, a bit of good news. More people now survive an overdose because of awareness and better medicine. But what happens to those people who walk away? I'm Jennifer Rooks, and on this episode of Roads to Recovery, we'll look at the science and personal stories of overdose and brain injury.
I've seen people who we woke up with Narcan and, they went to the hospital and they were discharged hours later, and then they went and did it again a couple hours after that. We've definitely had the same patient a couple times in a single 12-hour shift. And at that point, it's like, where's the disconnect? Where is that? It can't just all be this addiction aspect. There's got to be some sort of cognitive disconnect.
There is a cognitive disconnect. It begins when breathing stops.
An overdose, an opioid overdose in particular, suppresses the respiratory system, your breathing. And your breathing either slows down or stops to where the brain is not getting enough energy. It's not getting enough blood. So when you stop breathing, the brain stops getting the blood that it needs, and that causes you to lose consciousness. And we know that denying the brain of oxygen can very quickly turn into cell death.
The result is often brain injury, but it's a different kind of brain injury than most. The more common brain injury, traumatic brain injury, is caused by a blow to the head. This, called anoxic and hypoxic brain injury, happens when not enough oxygen reaches the brain. John Corrigan, a researcher on the topic, explains.
The thing to understand is that the brain is like a hog for oxygen in our body. I mean, for its small mass, the amount of oxygen it wants and needs to do what it does is way out of proportion. And so when while the whole body is being denied oxygen, the bigger users of oxygen are what are more likely to be affected. And in the brain itself, then, some of the big users of oxygen are what will sustain the most damage. damage. So we know that includes, for instance, the hippocampus, which is the part of the brain that's involved in creating new memories. We know that the cerebellum, which is in the back, and it's a big user, and it's very involved in balance and coordination. But we also know that some of the connections from the midbrain to the frontal areas are also affected disproportionately by the loss of oxygen. And so we get, with an opioid overdose, some of the same problems that are characteristic, that are kind of the fingerprint of a traumatic brain injury.
This is home video of Ryan Branshad, shot years ago by his mother. That's him, number 40.
Has a great sense of humor, which has helped him. He loves sports. He loves animals. Really just a helpful, good kid.
You didn't want me to sit with you,
Ryan is now 37 years old. His mother, Lori, had imagined she'd be a grandmother by now. She spends a lot of time with him at Rose Meadow Acres in New Boston, New Hampshire. It's a residence for people living with brain injury. In 2005, Ryan overdosed on heroin.
Ryan did have a history of substance use. He started at a job he was at. He had a headache, and someone had given him an OxyContin for the headache. And he was probably only about 16 or 17 at the time. We didn't know immediately, but things started disappearing from the house, from his room. He started to always not have enough money to pay his car loans or his car insurance. He was getting more introverted and quiet. And he finally did speak to me one night and tell me what was going on and what had happened. From the first time that he had taken the opioid, he was not able to stop after that.
If you want to take turns, we can take turns.
Of course. Lori says she and Ryan's father tried to help their son.
Beautiful day, Ryan.
They even called police, thinking jail was the only safe place for him.
I was scared every day. Every day. Scared of the phone call that was going to come to find out that he had overdosed and died. That was my biggest fear. I always used to say that he would either turn around or he would die. There was two options. I never thought of the middle option of him actually overdosing but surviving with a brain injury. He knows who I am. He smiles, so I think he understands what I'm reading to him or when I'm talking to him.
Look at that.
But the way they described it to me was that the different parts of the brains were firing, but some of them were not connecting.
Ryan's brain injury is severe. Not all are.
I was using drugs. I was getting them from the pain clinic. They were giving me 120 OxyContins a month. Then I was getting my Adderall and my Klonopin from my primary care doctor. Because I have a bad back, everybody thought it was okay to give me what I wanted.
That led to more misuse. Eventually, Mary Raniker went beyond the threshold and overdosed. She lives with a brain injury.
Anoxia, brain anoxia. And so that affects my short-term memory. Like a lot of times, I will repeat myself. I will tell you the same thing 3 or 4 times, you know, not even realize I'm doing it. I still crave. The addiction is always going to be there. It's a day-to-day struggle.
Did any doctor talk to you about, did they ever look at the brain injury and the substance use together as you treat both?
No.
What is your life like now?
It's good. Yeah, I really, like I said before, I really like it here. If it wasn't for my sister, I don't know where I'd be. And the crying has a lot to do with the brain injury. I'm surprised I didn't cry before. But yeah, I'm happy now. I am. I think I don't want to go back to that, where I was before.
Of course.
Mary and Ryan's stories differ in some ways, but they share a common chapter: a substance use disorder that led to their brain injuries.
These frontal areas, these connections from the midbrain to the frontal areas that really make the connection between traumatic brain injury, anoxia or hypoxia from overdose, and substance use disorders. That really is the glue to that relationship, because it's this frontal part of the brain that we use for doing what's expected of us as adults or even kids in society.
We're far into this opiate issue nationally, that we're very comfortable recognizing an overdose and very comfortable treating an overdose. Not happy about it, but of course we're, I think, getting better and faster at it and providing Narcan to people, outpatient and the first responders and police cruisers, things like that. But what we're not doing is figuring out what happens afterwards. We think that once they've been reversed and they walk and talk, they're probably okay. When in fact they may not be. Very good. Thanks for coming down.
Yes. Deepak Bhatti is an emergency room physician at St. Joseph's Hospital in Nashua, New Hampshire. He began his medical career as an EMT, so he likes to spend time riding along with Tracy and Susan.
No, they go to the emergency department, we Narcan them, they feel better, they want to leave, and then all of a sudden we've not been able to assess, has there been a traumatic brain injury, so then.
Dr. Bhatti likes to set goals for himself. He runs marathons, often trailing far behind his wife. And he is committed to bringing attention to what happens to the brain during an overdose event.
We're starting to see that over time, people that may come to the emergency department more than once for an overdose, we're actually seeing a change in behavior, a change in their socioeconomic status, just anecdotally. And so I think more research needs to be focused on this particular population. They seem to be slipping through the cracks.
Things like insight, impulse control, cognitive flexibility, planning, organizing are all going to be harder in that individual. Even though when I talk to them, I may not detect it at all, but that's there. So first, the substance abuse professionals need to understand that that's a possibility. They need to screen their patients so that they know that history is there. So, how many brain injuries have you had? When was your earliest? Because maybe that childhood one makes a difference. What was the worst? How many overdoses have you had? How many Narcan resuscitations have you had? These are all things that a substance abuse professional should know.
So we got 2 milligrams of Narcan on board.
Naloxone saves lives, but it doesn't fix everything.
The duration of onset is usually longer than how long the Narcan lasts. So What we've traditionally done is if somebody has overdosed, then the paramedics get there or the EMTs get there, they give them Narcan. They wake up, they still insist that the patient be transported to the hospital. Most times the patient agrees. And then we here watch them for about an hour, give or take, because we know the Narcan will only last about 20 minutes. At which point they may still have the narcotic in their system and without taking any additional medications can actually re-overdose.
Stay right there, Christina. The fire department was breathing for her using a bag valve mask. Another 2 milligram, 2 milligrams were given, so she got a total of 4 milligrams of Narcan. She's now awake and she's vomiting in the back of the ambulance.
There's been this assumption that if you get naloxone after you overdose, you win.
Danny's on, but I think he's on a call with us. We're running ragged.
What has not been talked about is that yes, you live, and that's the most important thing, but you may have a brain injury. And that's the population that probably would be most likely to be overdosed.
Lindy Keller is a treatment and recovery specialist at New Hampshire's Department of Health and Human Services. She and Dr. Vadi are part of a team working on a strategic plan for the state. It will address how to deal with a combination of substance use disorder and brain injury.
We need to get it out to the families and friends so that they know that what they may be seeing with this person is not just a result of their substance use disorder, but they may need more help than that. And then I think the other most important population is getting it out to the substance use disorder treatment providers and the medical providers who are treating the overdoses and then subsequently maybe treating the the opioid use disorder.
The community programs.
One of my missions is to help substance use professionals understand the importance of knowing what the brain injury history is of the person across from them. And the reason I believe that is that they can look just like all their other clients, but they're not the same. And the reason they're not the same is because of this frontal area functioning, what's sometimes called executive functioning.
6, did you stay conscious or not? Not.
What we see is that it really undermines what's called the therapeutic alliance between the individual being treated and the therapist. And so when that's undermined, you really weaken the ability for treatment, whatever it is, to be effective longer term.
The family, friends, doctors, all the providers in the person's life should be cognizant that once they've sustained some form of an overdose, we need to be very careful in watching psychological changes, socioeconomic changes, personality changes, to say that this might not just be the person in who they are, but rather they're changing into something they didn't intend to, and providing support structures for that.
We have to prevent the overdose in the first place. And that means getting out harm reduction messages to folks who are using opioids, to letting them know that this is an issue.
My downfall was, my mom's alcoholism and later on her drug use kind of landed us living on Hampton Beach.
That's where Ryan Fowler began to use drugs and sell them. On several occasions, first responders pulled him back from the clutches of an overdose.
It's really awful because if you think about it in terms of like what's happening, your brain is essentially shutting off from the frontal cortex all the way back to the brainstem. And then once you're revived by naloxone, it comes back like 0 to 60 really quick, but there's no memory recall, there's no critical thinking, there's no executive functioning. It's just a very intense fight or flight response.
Racism, classism.
Ryan followed his mother's lead and found treatment. He is sober and works as a recovery specialist at Granite Pathways.
So just to give you a real quick overview of what opioids do.
He teaches harm reduction skills and believes that anoxic brain injury can be reduced. quite simply.
Or we're going to be paying attention to the breathing, and so we really want somebody to be breathing, 12 to 20 times per minute or more. If it's right around that 12 breaths per minute or less, then we're in a really dire situation. And if that's the case, we're going to perform rescue breathing. If we want to reduce the risk that someone is going to have a permanent anoxic brain injury, we need to be teaching rescue breathing. We need to be providing rescue breathing masks. And this is just a one-way airport. They're not very expensive. I think they're about 50 cents a piece. We're going to do a finger sweep of the person's mouth to make sure that there's nothing that they're going to choke on additionally. And essentially, it's a, mouth-to-mouth cootie protector. We are going to lift their head back and tilt their chin up. So you put this over someone's mouth who's experiencing an overdose. And with 2 full lungs of our breath, we're going to blow our oxygen into their oxygen. So. And you can breathe for them indefinitely. So their antidote for an opioid overdose is oxygen. Naloxone simply gives the body the urge to breathe again. And in doing this, you will see that the color comes back into their face and their chest rises. And we can give them a breath of our oxygen once every 5 seconds indefinitely. And it's really, not only a matter of life and death, but the quality of life.
That advice is endorsed by the Department of Health and Human Services and many other organizations. However, the treatment and recovery that follows can be a challenge.
I think what's really difficult to navigate is the situations where every time I overdosed, I was brought to the hospital, I was essentially able to walk out without any sort of meaningful intervention and go right back to what it is I was doing. And that's really kind of scary because, like I said, there's no memory recall, there's no executive functioning. And so I have walked out of a hospital and gotten picked up by a family member and truly believed at that point that I had never overdosed.
One of the big differences when you have a person with brain injury and a substance use disorder is that when you think treatment is over, it's not. That when you think you've gotten the person to a place that they are in charge of their substance abuse now, they're in control of it, then you may not for the person with brain injury. And that one of the things you really need to be thinking about is what supports am I going to put in place to make sure that this behavior stays over time.
It's changed from you treated an overdose, pat yourself on the back and discharge them, to now more of a conversation. Okay, why did this happen? What's going on in your life? Do you have a job? Who do you trust? And hopefully you don't see them again. And then setting them up with social services. Sometimes I'll send a message to their primary care doctor saying, hey, you mind touching base with this person? It's a lot more comprehensive than what it used to be.
Part of the problem is that those things I talked about, that cognitive impairment and emotional dysregulation and impulse control, can be misinterpreted by other people. Like they're not really trying. Somebody misses a lot of appointments. They're just not committed to their treatment. The fact that a person who's been doing well in their recovery and then suddenly relapses because of their impulse control. And there's a sense that we don't need to fix this, that this is the person's fault. They're not doing what they should be doing. They're not trying hard enough. Those kinds of interpretations, I think, are really important for folks to recognize that if this person has had multiple overdoses, they may be trying as hard as they can, but they're limited in their capacity.
Ryan Branchard was alone in his apartment when he overdosed. Without oxygen, brain injury can occur within several minutes. Ryan was found several hours after overdosing. The effects for him are lifelong. Lori hopes that awareness will make a difference so that other mothers and fathers don't fear the phone call she received.
I would like Ryan's story to help someone else by visually seeing what can happen. Ryan is my only child, and it was so sad to think about a future where he wouldn't have a family and I wouldn't have a grandchild and I would never hear his voice again. He wouldn't fall in love and get married. Those things were very sad to me. But as time went on, we developed a really, really good relationship. And I love where we are. I love where we are, and I wouldn't give it up.
The team that Lindy Keller and Dr. Vadi is a part of would like to see first responders trained in recognizing brain injury and overdose survivors. That way, that information could be passed on to treatment and recovery professionals. I'm Jennifer Rooks. Thank you for watching Roads to Recovery.
Thank you for sharing that, Monica. I think that was really good video. And someone even asked, maybe we should add a question to the BrainSTEPS referral intake, asking a question about opioid use or, Narcan administration. What do you think about that?
Yeah, there is a question that Dr. Corrigan, who you saw in this video, he also developed the Ohio State screening method, the TBI ID screening method, to add something for overdose, which obviously is not a traumatic brain injury, but that he's become invested in. So there is a question that's being delivered in a standard way. I don't know that there's any research behind it. There's research behind his screening tool, but not with this specific question, but I can send that to you, Brenda.
Okay, that'd be great. Well, everyone, Monica, thank you for your first presentation. Monica will be back after our break for 15 minutes. We will break until 10:30. And then Monica is going to do a presentation on transition resources available in the state of Pennsylvania for students after brain injury. So 10:30, we will be back on. So you can leave your computers on so you don't get booted out. And then we'll resume at 10:30. Okay, everyone, welcome back. It's 10:30. Monica, are you here?
I'm here.
Okay. I'm going to stop sharing my screen. Monica, if you want to go ahead and share your screen. Monica is now going to present to us on transition resources for students in Pennsylvania post-brain injury. So this is really important because our BrainSTEPS teams all have students that are going to be or are currently transitioning. So really having a good understanding of what is available in our state to help support students in some way after they're a certain age, like 18, or once they graduate from high school is really important. And also, you can access the handouts. So in the chat feature, I put the link to the handouts. You can also find the link to the handouts in the email that Patton sent with your Zoom link. I know that was a little confusing, but it is in there. It's one of the last links. And if you have any questions, please type your question in the Q&A box, which is on your widget for Zoom. You'll see chat, you'll see Q&A. Please put them in Q&A, and then Monica can help answer them at the end. Okay, Monica, go ahead and start.
Okay, so this is a big switch in thinking here. So now we're not talking about opioids anymore, but generally, what are some of the transition resources for students in Pennsylvania? And there's, Pennsylvania is fortunate in many ways in the amount of resources that we have available. It's not a perfect system, certainly, but there's a lot there. So I'm going to be talking about resources available for adolescents, and these are available for adults as well, but they're also available for adolescents, some starting at 18, some starting at the beginning of adulthood, 21, but you need to be prepared for those too. And the families need to know about those because kids who graduate from high school will be entering into adulthood fairly soon. So I'm going to be talking about the Pennsylvania Head Injury Program. You may have heard that called HIP or FIP. A new program that's rolling out this summer called Acquired Brain Injury Program, also through the Pennsylvania Department of Health. I'll talk a little bit about Medicaid waivers, which currently is called Community Health Choices. I'll be talking about the OBRA waiver, Office of Vocational Rehabilitation, and the Pennsylvania Neuro Resource Facilitation Program. So the Pennsylvania Head Injury Program, I always start with this one because it is really such a flexible resource and one that we recommend that as many people as possible take advantage of if it meets their needs. So I'm going to give you a little bit of background on it, which impacts eligibility. So it was created by legislation in 1988 through the Emergency Medical Services Act. And so, when you see later that eligibility has to have been after a certain date, it's related to when the legislation was enacted. It's not a judgment about how long post-injury a person is. So the Pennsylvania Head Injury Program is operated by the Pennsylvania Department of Health, which is the lead state agency for brain injury. Every state in the nation has a lead agency for brain injury. In Pennsylvania, it's the Department of Health. It's not always the Department of Health. It varies from state to state. And so what the Head Injury Program does is funds rehabilitation services. It's not a program that you go to. It's a program that funds rehabilitation services for individuals with traumatic brain injury specifically, not any other form of non-traumatic acquired brain injury. It funds resources for up to $100,000 or 1 year of service, whichever is reached first. And that can really get a lot of services for someone. It's not meant to be a long-term program support. It's meant to be a short-term support and often really fills that gap after a person's rehab services that were provided through their medical insurance comes to an end, and this person still needs rehabilitation services. One of the great things about this program is that it's really flexible. The services can be provided in an outpatient setting. People can go to a rehab provider for it. It can happen at home. There are some providers that you don't go to them, they come to you. Or it can be provided in a residential facility. And there are 13 providers, brain injury providers in the state of Pennsylvania, who have contracts with the Department of Health to be able to provide treatment through the head injury program. So it's not as though this funding can be applied to any provider. It has to be a provider that has contracts with the Department of Health for the head injury program. And I have to say, when we review this information with consumers, sometimes there is some thought that maybe this is a $100,000 grant. It's not. It's $100,000 that goes to the brain injury provider for providing services that have been approved, come from a needs assessment, and are reported on regularly. So to get into the head injury program, a person has to have a traumatic brain injury that is certified by a physician. There's a certain form that has to be completed by a physician that certifies that the person has a traumatic brain injury and that that's causing the problems for which they're requesting funding. They have to be 18 years or older. Now, this is a new development. For a very long time, it was 21 years or older, but now it is 18. So this is something for you to really consider for your kids who are in a transition phase. They have to be a US citizen, and they have to be able to prove that, usually with a birth certificate. Passport would be accepted. They have to be a PA resident at the time of injury and application. And this is sometimes confused. They don't have to have been injured in the state of Pennsylvania. They could have been in Hawaii on vacation, but they have to have been a resident of Pennsylvania at the time of their injury and at the time of application. So for many of our adults who are applying, their injury may have been 10 years ago. For your students, it'll be probably a little bit easier to time this because there has to be documentation of residency at time of injury and application. And there's some help in that. This is a very complicated application process, and we'll talk about some assistance in completing it. Other financial resources for rehab have to have been exhausted. So if this is a student who still is getting rehabilitation services through their health insurance, they wouldn't be eligible for HIP until that is exhausted. And they need to meet income guidelines, which will not be an issue for students because the Department of Health, when reviewing these applications, looks at the individual's income, not the family income. So, the amount that is the cutoff changes from year to year, but it's based on a percentage of the poverty level, and it's usually somewhere between $33,000, $35,000 a year that the individual has to earn less than that in order to be eligible. So as I said, it's a really complicated application, lots of documentation required, forms to be filled out, and for a long time, when the head injury program was first initiated, there were very few applications, and very few applications, even if they came in, that were completed to the point where they could be enrolled in the program. The Pennsylvania Department of Health recognized this, and with some input from the advisory board, the Brain Injury Advisory Board, developed a program to help people complete the application, apply for services. And that program is called Pre-Enrollment Assistance. So whenever someone requests an application for that Pennsylvania Head Injury Program, they're automatically referred to the Brain Injury Association of Pennsylvania to assign a pre-enrollment assistance coordinator to assist the individuals in their homes and in their communities with the application process, and to provide information about resources. Once this program was put into place, the number of applications increased dramatically. It's a great service. Again, through contract with the Pennsylvania Department of Health. So if you want more information about the head injury program, there is a HIP RAC card, and this is the link to where you can find it. It just gives some of the information that I've just told you, but it also includes the phone number. The only thing you need to do to start this process is to make a call to this number, which is the Pennsylvania Department of Health, and say you would like to request an application for the head injury program. You can do it, a family member can do it, an individual can do it, can make this phone call. They'll ask a few basic questions to make sure that, you know, that the person is even potentially eligible. They won't go through all the eligibility criteria, but they will ask, does this person have a traumatic brain injury? Are they a US citizen? How old are they? Where do they live? That kind of basic stuff. And then if it looks like it has some potential, they will mail an application to whatever address is given, the individual, another point of contact, and then they'll be assigned a pre-enrollment assistance coordinator who will reach out to them by phone, by mail, a variety of ways to start helping with the application process. I will tell you that I've seen so many people benefit tremendously from this program. I mean, right now there's a waiting list, and it's not just because of COVID-19. There has been a waiting list for a while. It's not long. It's like, you know, sometimes 20 to 30 people, and people come off it, you know, regularly. So I would encourage you, even if a person's on a waiting list, to apply, because it really does some good things. I'll give you a couple of examples. Like, I know of an individual who was really in the community in a, you know, not really knowing, not able to continue to live with his family, needing to get his own place, you know, but not really being totally able to manage his life on his own as a young guy. And the, you know, the case manager and the rehab team that worked with him, once he found his place to live, helped to set up a relationship with his bank. They took him to his pharmacy and really put all the some systems into place to make him be able to manage as independently as possible. I've also seen people who are, you know, not in the workforce and maybe not ready to be in the workforce yet, but under the head injury program, they can do some pre-employment work, helping people to figure out what they're good at by maybe doing some work trials. You know, there's really no limit to what they can do as long as it's rehabilitation services. They don't do things like home accommodations. You know, they don't provide personal care assistance. It's all about rehab. But rehab can take on the form of cognitive rehabilitation that can even be academic coaching. Like, I know of not that all the providers have their own set of things that they are, you know, they will tell you that they offer, but many of them offer academic coaching, which means there could be a student who is finished with BrainSTEPS, maybe, you know, going to post-secondary education, needs some supports. You know, the head injury program will pay for a period of time where somebody, a brain injury specialist, can work with that individual on all the things that it takes to be successful in school. And that can mean the academic piece, but it can also mean the social piece, the emotional piece. So it's really a very flexible service. This new program that's coming out, and the last time I heard the estimate was July, so it's coming pretty soon. It's also operated by the Pennsylvania Department of Health in recognition that the Pennsylvania head injury program is limited to individuals with traumatic brain injury, and that individuals with non-traumatic acquired brain injury need many of the same services. And so they were looking for a way to provide something to that group. It's not the same as the head injury program. I'm not exactly sure all the services that they're going to be able to provide, because it's hasn't been rolled out yet. But they are rehabilitation services, and it's age 18 to 21 specifically, recognizing that kids who are no longer in school, and I know kids could still be in school through 21, but many are not, that there is this gap between 18 and 21 when services are available, because the next level of service for people would be a Medicaid waiver, but they start mostly at age 21. Anyway, it's an attempt to meet the needs of individuals who have fallen through the cracks historically. So I can tell you that we know that the services can happen in an outpatient setting, a day treatment program, or home and community-based setting, meaning that the people that rehab provider would come to the individual, they wouldn't be going to a facility. Not residential. Residential rehab is not available under this program. And again, it's the same phone number, the 717 number I gave you for the head injury program, but they also said you could call the brain injury helpline. And as soon as I get more information from this, I'll pass it on to Brenda. There is no tip card available yet. Everything is under review, but it's coming up, and it's exciting to see something for this particular group of individuals. So Medicaid waivers. You know, you may be familiar with waivers that used to exist. There used to be a variety of waivers, including the ComCare waiver for traumatic brain injury, the independence waiver for any type of physical disability. And just an aside, a brain injury is technically a physical disability, even though some people think of it more as a mental disability because it affects cognitive function. A brain injury is an injury to the brain, a physical injury to the brain, an organ of the body. So it is a physical injury. So now there is no more ComCare waiver, no independence waiver. You know, any of the waivers that used to exist have all been rolled into one waiver called Community Health Choices, and it's been transitioned to managed care. So meaning that there's a managed care company that does all of the assessments, enrollment, ongoing service development. And there, I don't know if I list them on another slide, so I'll talk to you about them now. There are 3 managed care agencies in the state of Pennsylvania that people who apply for a waiver, if they're enrolled, will be asked to choose among. There is UPMC, and they have to cover the entire state. So even though we think of UPMC as Western Pennsylvania, they are able to manage the care for people in any part of the state. So UPMC, AmeriHealth, which is many of the Blue Cross products, and Pennsylvania Health and Wellness. So the waivers are for individuals who are 21 years and older, and they will serve people with all types of disabilities. There is one exception of a waiver that wasn't transitioned to managed care, and that's the OBRA waiver. And that's because it serves individuals from 18 to 20. And so it fills that gap again for kids or adolescents who are out of school and not yet eligible for community health choices because they're not 21. And so the language that is stated is that the disability must result in substantial functional limitations in 3 or more of the following life activities. And if we think about these, we'll see that many of these overlap with the effects of brain injury. Self-care, communication, learning, mobility, self-direction, and capacity for independent living. Now, just as an aside, I have to say that while that is the language and the intent of the waiver, and it was the language and intent of the other waivers, so should transition to managed care as well, it's not easy to assess eligibility in a person with brain injury. And we're certainly working with the managed care companies on that. So to become waiver eligible, there's a parallel process, 2 parallel processes. One is financial eligibility and one is functional eligibility. And the financial eligibility is done through the county assistance offices. The person either has to have Medicaid or be applying for Medicaid and be eligible for that, which is very different from the head injury program that only looks at individuals' income. So the reason for having and applying for Medicaid is because these are Medicaid waivers. And the word waiver basically means that they're waiving the regulations of traditional Medicare and offering something additional for people who have needs that traditional Medicaid can't meet, some long-term services and supports, which I'll show you the menu of those soon. But then there's the functional eligibility, and this is where it becomes challenging. So everyone who applies will undergo an assessment to determine what level of care is needed. And that happens in the person's home. So someone from the Area Agency on Aging will come out to the home, interact with the individual applying, do an assessment called an FED, a functional eligibility determination. And based on the results of that, we'll say this person does or does not meet the level of care required to be eligible for the Medicaid waiver. And you can imagine the difficulty in assessing a person with brain injury at the various levels. So if a person has clear physical dependence, maybe they're not able to do things for themselves like daily care, self-care, it's clear that they are going to be eligible because you can see it, and a person can usually describe it, or their family member can describe it. But for a person who has maybe moderate brain injury, who the effects are totally cognitive, who truly can't function independently without supports, they would greatly be at risk, but who look okay, they walk and they talk and they can answer all of the examiner's questions, it can appear that they don't have needs, especially if the individual isn't really able to articulate them. Maybe they don't recognize them, or maybe they just, aren't able to explain it. So it's really important to have someone who knows the person well to participate along with the applicant so that the assessor can really understand the needs. I mean, I'll just give you an example, and this is an adult example, but I'm sure you could come up with some and suggest them to me for adolescents. An assessor went in, was interviewing a gentleman, his wife was there, and they say to this man, can you prepare your meals? And he says, oh yeah. And they say, well, what did you have for breakfast? And he says, I cooked bacon and eggs. And the wife is shaking her head in the background because that's not accurate. Did this man ever make bacon and eggs for breakfast? Yes. Maybe he did it most of his life and can't do it now, but hasn't come to understand his current impairments. And his memory is serving up this experience of making bacon and eggs, and he believed that he did that morning. That can be effect of the brain injury. And when you ask the wife, she'll say, he has not done that in 10 years. This is a real example. I mean, you couldn't make this up. And other things, a person, can you use public transportation? Oh, sure, I can get on the bus and I get on it right here. What bus would you take to get to school or whatever? And they can tell you what it is. And do you need any help? No. And maybe the parent is behind them shaking their head and then says, yes, he can get on the bus and he knows how to pay for the bus and he has a trans pass or whatever, and he gets on the right bus at the right time, but he doesn't notice his stop. Either his attention fails, or he doesn't process it, or he doesn't remember to get off, and he's like in 2 counties over and didn't get off at the right stop. So, it takes a lot of sophisticated questioning of the subtleties of this. Yes, a person can walk independently in their community, but then you find out that, their behavior is such that they're going to be at risk because they're disinhibited, and they can become victims, or they can become, in a position of vulnerability. So assessing someone with a brain injury, if it's not something that can be observed, is really difficult. And some of the assessors really don't see it, or even they don't even collect the information that would that would help them to understand what this person's needs are. That's why it's important to have someone who knows the person well. I will tell you that we've been working at BIA-PA with Aging Well, which provides some services to all of the area agencies on aging. And just today, we rolled out a training for assessors on the complexities of assessing people with a brain injury. And it's going to be a required competency for all assessors to complete this training and pass a test on, how to assess a person with brain injury as far as functional eligibility. I'm just going to back up a second here. The level of care that's required to be eligible for a waiver can be misleading because they use a level of care called NFCE, which is NCFE, Nursing Care Facility Eligible. Nursing Care Facility Eligible. So that doesn't mean a person has to be in a nursing home or that they're going into a nursing home. what it means kind of in the most global sense is that if this person didn't get services and supports in order to live independently in the community, they would be vulnerable to, at some point, need nursing care facility placement. And that's not an easy determination to make. So we're really working on it. The other thing I would say before we go on is that the Pennsylvania Head Injury Program, which we talked about first, has to come first because of this requirement that it's a payer of last resort. So once a person has been determined to be eligible for a Medicaid waiver, they will never in their lifetime be able to become eligible for the head injury program. It's just a little intricacy that's important to understand as families are making decisions as to what to apply for and what's the most appropriate resource. And as questions come up for families, I would encourage you to have them call the Brain Injury Resource Line. You'll have that number on the slide before we end, just so that they can really know where to go for help if they're not sure what is the best next direction. So Medicaid waivers provide funding for home and community-based services for qualified individuals, and they can provide long-term services and supports. And that could include residential habilitation. I'm going to show you the whole menu list. And to apply, you call this phone number. Here are some of the services that Community Health Choices can provide. It's a very long list. I'm going to highlight a few of them. So if you look in the right column, about halfway down, you'll see that I've highlighted or made bold personal assistance services. This is the service of somebody to come to the person's home and to help them with everyday activities, help them to cook their meals, help them to do their laundry, help them to manage their morning routine, whether it's helping them to shower, whatever it needs to be. Like basic skills like morning routine and showering to more complex, higher activities of daily living, like managing your shopping and your cooking. So waiver assessors and needs and service coordinators are very good at authorizing personal assistance services. That's something they understand well, and if a person is deemed to be eligible, the service coordinator is likely to authorize personal assistance hours. And while that's really helpful to some people, it really isn't necessarily the only thing a person needs, or they might not need that at all. I've highlighted some of the other things that are on the menu that don't get authorized as often as we would like, but that we really want to be considered in the needs assessment. So the other things I've highlighted on the left side are behavior therapy. They can authorize treatment with a professional, hopefully a professional with brain injury experience. They're not quite as, their provider network is not all people with brain injury expertise, whereas the head injury program is only brain injury providers. The Medicaid waivers has a much larger network of providers, but the individual who is being served and their family member can say, we need to work with a brain injury provider, and then they'll get the appropriate service. Behavior therapy, cognitive rehabilitation therapy, therapy to help a person develop organizational strategies or to develop, their ability to plan for things that they need to do. It doesn't necessarily, the goal isn't to improve someone's memory, it's to develop strategies so that a person's memory can function effectively in their daily life, as well as their executive skills, whatever cognitive rehabilitation is needed. I could list providers with brain injury providers who have contracts with the Office of Long-Term Living and the managed care companies who are able to provide cognitive rehabilitation therapy. It just has to be put into the service plan, and it's not put in there very often. And we're hoping that as we educate more families, that they will be the ones to contribute to the needs assessment and let the service coordinator know what it is that they really need. There is a document that I could provide if you're interested that lists all these and what they're called, and also has a little worksheet, a few pages of a worksheet prior to it to get the individual and the family to think about what the needs are, so that when the service coordinator comes to their home to develop the service plan, they can say, what about cognitive rehabilitation therapy? I really need that because. Sometimes the advocacy has to come from the patient and the family. It can authorize counseling And not necessarily, because of a mental health disorder, but because of the counseling that's needed for a person to understand their brain injury and to, learn how to use some strategies to cope with their brain injury. CHC can do some employment skills development and all that goes with that, job coaching, job finding. This is new. Medicaid waivers didn't always do this, and most people went directly to OVR, and we'll talk about OVR. But for those people who are not OVR eligible, for whatever reason, maybe they're not really ready to work. OVR wants to provide service to people who are, ready to actually become competitively employed. If they're not OVR eligible at this time, they can get some skills development through the Community Health Choices waiver. And the other thing on the right-hand side, near the bottom, you'll see that I've bolded structured day habilitation. So this is something where the individual can go to a brain injury clubhouse, and there are only a couple of those in the state, or to a brain injury program that has day programming. This is something else that is not often thought of. Residential rehab, which I didn't, residential habilitation, which I didn't bold, but is like, 4 bullets up from that, is sometimes authorized. The assessors or the service coordinators recognize when someone needs to live in a setting that has supported living. So that gets authorized sometimes, but I'm going to give you an example because I've been doing a lot of training with service coordinators. Here's an example someone gave me. They had a guy in a nursing home who was young. I think she said early 20s, and she didn't think he belonged there, and he didn't want to be there. He had a brain injury, and he was probably put into a nursing home early in his recovery when he couldn't live independently, and maybe now he can. He's made a lot of progress, but probably didn't have family supports to go anywhere else. So she wants to help him get out of a nursing home. And so her intervention is to help him look for apartments and help him get an apartment. Well, there's a big gap between living in a nursing home, having all of your meals cooked for you, having your bed linens taken care of, having structured opportunities for activities, not really being able to go out without structure, to living independently in the community where you have to not only manage your own needs, but all of your safety risks, all sorts of things. And she didn't know that there was something that she could offer him to assess that. And certainly, they could offer an evaluation through a service through a brain injury provider to evaluate whether this person is ready for the community. Maybe they need residential habilitation for a little while. There are several residential rehab providers for brain injury across Pennsylvania that do just that. A person lives in a small setting, maybe a house with 2 other people, maybe an apartment with a roommate, with a lot of structure and staff supervision to assess their abilities, and they advance from there. And this would have been a much safer plan than just helping someone to find an apartment. One of the things that that CHC can do that the head injury program can't do is personal care assistance, home adaptations, delivered meals. Like there are some things that they can absolutely do that that HIP can't. So for some people, this is the most important.
Happy birthday! Happy birthday to you. Happy birthday to you. Happy birthday, my darling. Happy birthday.
Yes.
Hi, Dr. Jenny.
Oh, I'm sorry. Can people hear me?
Yes, happy birthday to whoever.
Sorry. That's my grandson. What am I doing wrong? Okay.
Nothing. Just hit your mute button on your panel. You should see something on the lower left that says mute. If you just click that, and that's it. Okay, you're good.
Okay. Thank you, Brenda. So again, it's a great service, and for some people where it's very clear that they're going to need long-term services and supports and personal assistance and home modifications, this is the resource to use first. But for those people who might benefit from head injury program first, that's just something to keep in mind. So OBRA is a little bit different, and OBRA, as I said, is a Medicaid waiver that was not rolled into Community Health Choices specifically because it serves individuals 18 to 20. And a lot of the menu of services are very similar: residential habilitation, employment skills development, behavior, a lot of the same services. So for those age 18 to 21, this is the appropriate group. And I do believe you make the same phone call to apply. So there is a program called Independent Enrollment Broker, who is the kind of organization that helps manage this process to streamline the assessment. It began back in 2010, and here are the phone numbers to make an application. They will not ask you when you call the Independent Enrollment Broker a diagnosis, because the waivers now are for any disability that's not related to diagnosis in the way that it used to be. So I recommend that people, when they call, say, I have a brain injury, that offer that information, and I want assistance from a brain injury trained independent enrollment broker. I'm not saying they're going to get it, but to put it out there, because if the word brain injury is in their record, then the person who's doing the assessment will be better informed when they go into the home as to how to really assess a person with brain injury. So, Brenda, do you want me to wait for questions, or do you want, because these are all very independent of each other, do you want people to be able to ask questions about specific resources, or wait until the end?
It's up to you. If you want to take them now, we can.
If there are any questions about either the head injury program or the Medicaid waiver, it might be helpful to take them before we move on.
So we have one question about the OBRA waiver.
Yeah.
The question was, is mobility a key factor because it was prior?
Well, it's not supposed to be. But as I said, assessors tend to look at this concretely. And if a person is mobile and can get around, they might think that they don't need services. But the FED, the functional eligibility determination, goes much beyond mobility. It has questions about the ability to make decisions in everyday life. It has a memory section. It's supposed to be, and if I back up, let me back up here. If we look at the bottom statement on this slide, the definition is that the disability must result in substantial functional limitations in 3 or more, and mobility is only one of them. So self-care, communication. I mean, a lot of people with brain injury have communication impairments. Either they can't communicate their needs, they can't process the information given to them at a rate at which is functional. And then learning. How many people with brain injury are going to have impairments in learning and memory that are going to interfere with their everyday function? There's mobility, but it's one of 5. Sometimes the assessors focus on it, but it is not supposed to be that way. Look at the next one, self-direction. Being able to direct your own life. And so there are lots of people with brain injury who have trouble with self-direction. They may, not do things that are essential for their own function. They might not take their medications appropriately. They might not respond appropriately in an emergency situation. They might not be able to manage their finances in such a way that they can, stay in their apartment or their home. So learning, communication, self-direction, and then the last one is the capacity for independent living. So you can see that while there might be a focus on mobility because it's the thing that you can see, really there's much more that should go into it. And the FED, the functional eligibility determination tool, includes items on all these things. It's a great question. I wish I had a better answer.
Next question. Could a brain injury cause someone to do something they don't remember, such as theft, and then deny doing so because they simply can't recall having committed the theft?
Oh, that's a pretty, yeah, oh gosh, that's a loaded question. So, memory is very variable from person to person, and you're talking about episodic memory, which is a specific type of memory, remembering something that occurred, which is very different from semantic memory, remembering something that you were told or that you read, or prospective memory, remembering to do things in the future that you've planned to do. Episodic memory is it can be impaired. Certainly, I'm not saying it's not, but experiential memory has emotional salience, where some things are going to be remembered because of the emotional salience than others. Stealing something and not remembering doing it, I'm not saying it can't happen. I don't think it would be common, but it would require a good neuropsychological assessment to see if episodic memory is impaired. I mean, I can certainly tell you of personal clinical experience where I remember I was involved in an episode. This is many examples of this. Involved in an episode at the same time, a person with brain injury, and they recall it very differently than the way I recall it. Pieces of the memory can be fragmented, but you have to be really careful when a person is when there's an issue of crime and the intent to not be held responsible for that crime due to a brain injury. Doesn't mean that there aren't cognitive contributions to the intervention that to the behavior that need to be addressed, but they'd have to be on a one-to-one basis. We've worked with a number of people in the criminal system, and I can tell you there are things that people do sometimes that they not that they don't remember, but they didn't intend to do, where they were kind of, victims of a circumstance. I'll give you one example of a very young guy who was just hanging out, as is common in his neighborhood, an urban neighborhood. And he's outside of a store, which, a corner store, about 5 or 6 guys hanging around. And one of the guys, who has a Foot Locker bag in his hand, says to this individual with brain injury, "I'm going to go into the bathroom. Will you hold this for me?" I don't know if you hear any red flags in that, but I certainly do, and I know what happened. What happened was the police were nearby. The person who was holding the Foot Locker bag picked that up in the environment. The person with brain injury did not notice this, which is, an issue of who knows what, scanning, social awareness, whatever. He didn't notice it. Did the guy go into the store and go to the bathroom? No, he went into the store and went out another exit. And here is this person with brain injury holding this bag that has drugs in it. And he gets arrested. And so, he really had no intention. He didn't even know what was in that bag. And because of his cognitive impairments, he didn't recognize what was going on around him enough to say, "Hey, no, I'm not holding your bag." He didn't think it through as to what could happen. And so, a brain injury provider that was working with him was able to work with the justice system to keep him out of jail, and to just to work with the system so that he had minimal consequences of what happened. So I do see people with brain injury who don't really do what they're accused of doing, even though they're literally holding the bag. I've not known someone who's forgotten that they stole something. And I'm not saying it couldn't happen. It comes back to really looking at the behavior. And I don't know if the person who asked this question has any more details about a specific instance, but I've certainly seen situations, and this was with an adolescent, who his behavior was not directed by his internal goals. It was directed by the environment. He had a severe brain injury. He would take things. He wasn't intending to steal. He saw a hat, he put it on and walked out the door, because the environment was directing his behavior. He saw a hat. What do you do with the hat? You put it on. He wasn't intending to steal. Not like he forgot that he took it. It wasn't the intention of his behavior. So it can get pretty complex.
Monica, for the 18-year cutoff limit for some of these programs, they do not have to have graduated from high school. It's just if you're 18. Okay.
If you're 18.
And then for the head injury program specifically, the first program you talked about, if a student has had a brain injury and now they are 18 and they are addicted to drugs, could the head injury program cover drug rehab? Probably not, because the head injury program is about brain injury rehabilitation. And to be honest, I think what the head injury program would do would be to authorize an assessment.
because when a person applies, they determine whether they're eligible on the basis of the eligibility criteria. Then the next step is to authorize an assessment by a brain injury provider. And so that brain injury provider would then assess the person's needs and their situation. And my guess is that brain injury provider is going to say, this person isn't ready for rehab because the addictions have to be handled first.
Okay.
I'm not saying I agree with that, but I think that's what happens. And, you know, when we did the opioids presentation, I talked about braided treatment, like interleaving the brain injury treatment with the substance abuse treatment. And I think that's happening more and more often. But the head injury program isn't going to pay for substance abuse treatment because there's probably a payer for that through the person's health insurance, whether it be Medicaid or whatever it is.
Okay. And then there's one other question. I have lots of thoughts about this, but generally, how does CHC distinguish itself from people who may have primary diagnoses of dementia, ID, and also have a brain injury? I just want to understand, is this a backdoor entry to services?
Well, I don't know what that means, a backdoor entry to services. So maybe we could clarify, but Community Health Choices does not require any specific diagnosis. So a person with dementia could get Community Health Choices services.
Okay.
So I don't know, Brenda, what's your interpretation of backdoor services?
My interpretation of what Fernando means is basically that they could have dementia and an intellectual disability that are really the driving forces of the impairments, and they've also had a prior brain injury. Can they still get treatment that would help with the dementia and the ID issues?
Yeah, so Community Health Choices does not look at the diagnosis. They just look at the functional needs, whether it came from dementia, from a learning disability, from a brain injury, or any combination of those. They look at what the functional needs are. So I might not have explained this clearly. So once a person is found to be eligible financially and functionally, and they're enrolled in CHC, the next step is for a service coordinator from the managed care company to do a needs assessment with the person, and their families are welcome to be there. You're welcome to be there. The person who's applying can include anybody in these assessments that they choose. So that's when they look at what is it that you need, and then they develop the service plan. And the service plans can be adapted over time, and needs change. So what really it comes down to is, what does this person need? Does this person need adult daily living services? Do they need cognitive rehab? CHC does not define it by the disability. I think the challenge is getting the right professionals in the picture to provide those treatments, because the brain injury community is skilled at treating people with brain injury, and I think they could probably do a good job with people with learning disabilities or whatever, but not necessarily dementia. That's not an area of expertise, and the interventions for dementia are quite different. So yes, they can get all those services regardless of their disability, and they can get them at the same time. That's not the case in the head injury program. So if a doctor were to certify that a person, on the certification form, that an individual has had a traumatic brain injury, but they have co-occurring conditions, one of which is dementia, another of which is, say, schizophrenia, and that they're contributing more to the problems that are surfacing than the brain injury, then the head injury program would deny that person's eligibility. Okay. Does that help, Fernando?
Yes, he said that was my concern, that the wrong professionals would be providing services if the primary was ID or dementia. So I feel better that it would be carefully reviewed.
Well, I'm not saying it will be. I'm saying it should be. So it really becomes, and I know this is difficult for families, it really becomes, in some ways, until the service coordinators get better at this, incumbent upon the family to really advocate for what is needed. And professionals. I mean, any of you could be involved in a needs assessment meeting if the client asks that you be at the table. And I know service coordinators have told me directly, yes, you can do that. But for them to see it, to see what the need is, it's very difficult for them. We're doing a lot of training with them. They have so much turnover, and they're not trained in brain injury. They're not trained in any of these disabilities necessarily. Some of them have experience in it, some of them don't. So it really becomes an advocacy issue from the family to say, and this is what I said also, if you're calling the independent enrollment broker, say I have a brain injury and I want to be assessed by a brain injury professional, or not if you think it's a different disability leading the way. I've certainly seen people have service plans that look okay, and the agencies that are contracted with to provide those services are not the best agencies for that disability.
Okay.
So one more thing, because I'm sorry, I know I'm on a soapbox here, but because it's been such a big issue in the brain injury community. When we do our trainings with service coordinators, and I have to say 2 of the managed care companies, AmeriHealth and Pennsylvania Health and Wellness, have contracted with the Brain Injury Association of Pennsylvania to train their service coordinators. They've been very open to it, willing to put resources into it. And, I think it will bit by bit make a difference. But I've learned that in addition to teaching them about brain injury and teaching them about what functional impairments require services and what kind of services they might authorize, and using some case studies, I've also started to give them a list of brain injury providers and where they're located, so that they can start, because some of them don't even know there is a brain injury provider in their area. Some of them have never heard of the major brain injury provider. So how would they know to contract with them to provide these services? So I give them a list of all the brain injury providers that was provided to me by the Rehabilitation and Community Providers Association, and tell them that if they have a person with brain injury, they should be working with these groups. I'll get off my soapbox now. It's a tough area to really make an impact on.
Okay.
That's it for those?
Yes.
Okay, so I'm going to move on to OVR, which I'm assuming most of you know a lot about, but I'm going to cover it just to be thorough. So another transition resource is the Office of Vocational Rehabilitation. Every state is mandated to have vocational rehabilitation. It has different names in different states. In Pennsylvania, it's OVR. And, there are services for adolescents and there are services for adults. And some of your kids who are transitioning will be appropriate for the adult program, but I'm going to start with the adolescent services. So I'm assuming that you're familiar with the Early Reach Initiative, which is for individuals ages 14 to 21, specifically individuals with disabilities of any type. And every local office has an early reach coordinator. I'm assuming you have relationships with them, but if you don't, I'd really recommend that you develop relationships with them, because they are the door to services. The Early Reach Initiative can provide group services, and this is mostly like educational sessions on what is OVR, how it could help them, some basic things to think about developing career. Very general. I've certainly seen some of those services, and they've been very interested in doing these kinds of services. We at the Brain Injury Association have done a lot of work in juvenile detention facilities, and the Early Reach coordinator was very willing to come out and talk with these youth who were detained, and they did it on a regular basis. And I think it really did, give the kids a sense of where they could get hope in the future. But there also are individual services that can be authorized, and they don't require the same type of application and eligibility as the adult services. And, I'm not seeing these authorized as frequently as group services, but, I may not be in the loop, certainly in all the counties. This is only what I've seen. But they can work with individuals to do career exploration. You've got to really just request it. They also can provide funding for a work-based learning experience. We worked with a youth who, had 9 weeks of a work-based learning experience. I think it was at a Staples or some local store. And he was released from detention to do that work-based learning experience and ended up getting hired. And a work-based learning experience can be very effective. And job shadowing. You know, we worked with a youth who had always had the goal of becoming a nurse. And because of his brain injury and his cognitive abilities, it was probably out of reach for him, at least at that point. You know, nursing requires so much executive function, keeping track of a lot of information. You know, it's not a structured work where you sit at your desk and you do very concrete things. It's a difficult job for people with brain injury. But, you know, he was doing some job shadowing of other allied health professionals, following a phlebotomist. I remember one of the job shadowings he did, and it really looked like he might be interested in getting training for that. They can provide counseling on post-secondary education, and I apologize for the missing letter in education. You know, they can have an OVR counselor, or maybe an early reach coordinator, work with them directly on making some plans for post-secondary education. They can do workplace readiness training and instruction on self-advocacy. So there are a lot of individual services that, you know, you really, in my experience and the work that we did, we really had to advocate with the early reach coordinator to get these things to happen. I don't think they're the ones who do it. I think they have to take it to another level, but it definitely can happen and it can be very effective. Brenda, with your knowledge of what happens in the teams, do you think these things are happening, or
I think it varies.
Team leaders are aware of how to make it happen?
Yeah, I think it varies. I know we have a lot of discussions about vocational rehabilitation. I know there are waiting lists in a lot of places, so a lot of students are not even getting services at all.
Mm-hmm. Well, that was a big complication. OVR has been in some financial difficulty. I don't want to get into the details, but they did have to impose an order of selection, which was a priority list of who they would provide services for. And there were some criteria as to how you got into what order. I think that has been lifted. I'm not certain about that. Okay. It requires a lot of advocacy is all I would say. You know, I think we just kept beating down the bushes until we got some services for kids, and the services worked out well. I don't think it's an unwillingness to provide services. I think it's an educational issue. And you probably know that vocational rehabilitation offices, programs are required now from the WIOA Act, the Workforce Innovation Opportunity Act, signed into law by President Obama. They're required under WIOA to spend 15% of their budget on individuals aged 14 to 21. So you can help them do that.
That's right.
Okay, so services for adults, and I realize you're working with kids, but you know, some of the kids who graduate as they're transitioning, some will go to post-secondary education and some won't, and some might really be looking for competitive employment. If they've been involved in early reach all along and it's in their transition plan to get some services, hopefully they're ready for that. But if not, you know, they just, you know, the Office of Vocational Rehabilitation has very good services for adults. It's an issue of making them happen. You know, the individual has to have a disability. They have to have an employment goal. They can get diagnostic services, vocational evaluations. They can get counseling services, restoration services. I've even seen OVR pay for work boots for a person who could do this job but can't afford to buy work boots or some other, you know, visual services, something that would put the person in a position to be able to work. And then they can also provide direct services through approved vendors. So some of the work happens through the OVR counselors, but then they also have approved vendors who can provide some of these services. And there are many brain injury providers. I know they're more in urban than some of the more rural areas, but there are many brain injury providers who have contracts with OVR to do all of these things. So I always tell people when they're contacting the Office of Vocational Rehabilitation to say, or when they first meet with their counselor, to say, I have a brain injury and I would like my evaluation to happen through a brain injury provider, whether it's a vocational evaluation, You know, a brain injury provider is going to look at a person's ability to do jobs very differently than a evaluation that comes through a service that is not familiar with brain injury, because they're not going to recognize the needs in the same way. So I would really strongly advocate for that. I wanted to back up to say something else about vocational rehabilitation. Helping a person prepare for that meeting with a vocational counselor is really important, because when they get to the meeting with their vocational counselor, they're going to be asked questions that a person with brain injury might not be able to answer on the spot, or might answer in such a way that doesn't get them what they need. So they're going to be asked things like, what do you need? What are your goals? What do you want to get out of this? And you know, they might be given, once there's an idea that they're going to get some vocational evaluations or diagnostic services, they might be asked, is there somewhere in particular that you would like to get these services? OVR is very consumer driven in a positive way, but for a person with a brain injury who can't make decisions or generate ideas quickly, it's helpful to have somebody else besides the consumer be part of that interview. OVR is less open to that than some of the other agencies. It's just really a strong self-advocacy, which I respect. But preparing them before they go in is a way that you can have some ability to structure the person to be able to answer the questions without actually being in the interview itself. And so if they go in saying, you know, I really would like to work, these are the areas I'm interested in, you know, and the counselor says, well, we'll need to do an assessment of whether you're able to do that, for them to say, you know, I live in Pittsburgh. I know that there is that Remed does this. I'd like to get my assessment through them. Or I live in Philadelphia and I know that Moss Rehab does this. I'd like to get my assessment through them. Or I live in a certain county where Community Skills or Living Unlimited or Mainline Rehab will come out and evaluate me in my home and community. If they know that going in, that really does help, just to be prepared for answering questions. The other thing that we know, and this has come through in research, is that a person with brain injury does better in a place and train model as opposed to a train and place model, which probably as educators you're familiar with, but it might, an OVR counselor might say, oh, you're interested in doing some data entry work. Let me send you to such and such institute that prepares you for that. That's less likely to be effective than a person working with a job coach, doing data entry on the job and learning exactly how to do that job. Because a person with brain injury can come out of a training program and can't necessarily apply those skills in the work setting where the database is different and the issues around how to interact with the supervisor and coworkers and following instructions is different. So putting them in, doing an evaluation that says, yes, this person probably would be good at X job, and putting them in the job with a job coach to learn the job and develop compensatory strategies is much more effective than having them train and then get placed in a job. Okay, neuro-resource facilitation. This is a relatively new program. I think it's in its second year. It's funded by a federal grant through the Administration of Community Living. And it currently goes through May of 2021. Whether or not funding will be continued, you know, that's to be seen. But it is operated by the Pennsylvania Department of Health, and they've contracted with Community Skills Program to administer this program. It's for residents of Pennsylvania with a traumatic brain injury only, and this is always going to be the way that it happens with any funding that comes through the Administration of Community Living. The partnership grants are specific to traumatic brain injury, unfortunately. It does serve individuals 18 years and older. And so what happens if a person wants neuro-resource facilitation is that they're assigned to a facilitator who can provide information about resources, services, and supports. They can help the family navigate and pursue the supports. They can help develop a plan for ongoing support. They can partner with people to ensure that they can continue to get resources after neuro-resource facilitation is done. It starts with an in-person meeting, and the service is ongoing for 6 months. I think there's only one in-person meeting, and the rest happens telephonically or through video conference. I'm not sure which. But basically, the idea is that people might not be able to navigate resources. And we have the brain injury resource line where we can certainly tell people what some resources are. But if they need somebody to work with them for 6 months to access these resources, fill out all the applications, you know, and actually start to receive services, it can take more than a couple phone calls. So this is a 6-month service. It's relatively new, and we're hopeful that it will provide support for people in an ongoing way. So I would suggest that you, as students leave, that you let them know about this program. And, you know, we'll see what happens after May of 2021, but it's to help people navigate resources and to think about things that maybe you haven't. As you know, on the BrainSTEPS team, maybe you're not thinking of every resource outside of the educational world. And families sometimes need a long time to work through this process. So it's a new program. I would recommend referring anyone to it that you think is going to need help finding resources. If they are eligible for the head injury program, since this comes from the same department, Pennsylvania Department of Health, Bureau of Family Health, the first thing that Neuro Resource Facilitation is going to do is to see if they're eligible for the HIP program. And if they are eligible for that, they'll put them into that process and they will stop their work. You can't do both at the same time. I will say NRFP doesn't require the application that the HIP program requires. Neuro Resource Facilitator can help person to get into that application process, but it's very simple. You make a phone call. I think they only want to verify that a person has a brain injury, that they live in Pennsylvania, and how old they are. There's no documentation required, no big application procedure. So it's really an easy thing to start with. And there is a RAC card, and this is the link to it on the Department of Health website. Brenda, you can get them certainly to send you these RAC cards if your teams don't have them. And the program access is the same number. It's that 717 number that you'll see for the head injury program, for the acquired brain injury program, and for NRFP. Oh, I guess I didn't put this at the end, but I should have put the brain injury resource line. I'm guessing that most of you know about that, but the Pennsylvania, the brain injury resource line is at the end. I think the phone number is at the end of the opioids presentation. And Brenda, I could certainly send you some brain injury resource line wallet cards if that would be helpful.
That would be great, Monica. Yeah. And then
it's a first call.
I'm getting some questions from people in Pennsylvania who are asking if they could have this slide presentation.
Sure, I don't have any objection to that. Let me send it to you in PDF though. We do ask that people don't use the slides and change them. Mm-hmm. So when we share a slide presentation, we usually do it in PDF form just to maintain the integrity a little bit.
Okay.
If that's okay.
Yep. Okay, so thank you very much, Monica, for being here today. We're not going to be able to take any more questions right now because we're running a little bit over. Because we are running behind and our next presenter is here, we are skipping the break. If you have to go to the restroom, that's fine. Go ahead and go. But I do want to continue to our next session.
I apologize if I took more time.
No, it's fine, Monica. It's totally fine.
Okay. All right. Thank you, everyone. I'm going to leave the meeting. Brenda, you don't need me anymore, do you?
Nope. Thank you. And just so everyone knows, these are being recorded. You will have access to this summer. It will be posted on the Patent website, and it will be posted on the brainsteps.net homepage. But first, we have to get it closed captioned and everything, so it won't be immediate. And so with that being said, let me pull up my... Okay, so I'm really excited to announce our next presenter, Dr. Carol Jenny. She is coming to us. She's 3 hours behind us here in Pennsylvania. She's out in Washington, I believe. And I watched a presentation that Dr. Jenny had given on child abuse and brain injury about a year ago. And I've wanted to bring her in to you since then. So I'm very excited that she can be here. I know we have a lot of students in the BrainSTEPS program who have experienced brain injuries from child abuse. So her bio is, Dr. Carol Jenny is the Child Abuse Fellowship Director at Seattle Children's Hospital and a professor of pediatrics at the University of Washington School of Medicine. Prior to coming to Seattle, Dr. Jenny was a professor of pediatrics at Brown University School of Medicine and director of the Child Protection Program at Hasbro Children's Hospital in Providence, Rhode Island. Dr. Jenny graduated from University of Missouri Dartmouth Medical School and the University of Washington School of Medicine. She did her pediatric residency at the University of Colorado, affiliated hospitals, and at Children's Hospital of Philadelphia. And we have both states here today, Pennsylvania and Colorado. She was a Robert Wood Johnson Clinical Scholar at the University of Pennsylvania and received an MBA in healthcare from the Wharton School. Dr. Jenny has served on the faculties of the University of Washington and the University of Colorado. Dr. Jenny is past chair of the section on child abuse and neglect of the American Academy of Pediatrics, and she's the past chair of the Academy's Committee on Child Abuse and Neglect. Her research interests include abusive head trauma, internet child exploitation, and medical child abuse. She was a researcher at the Biomechanics Laboratory at the Africa Child Care Institute, Nara, Japan. So welcome, Dr. Jenny.
Thank you. Can you see my slides?
Yes. Yep.
Yes. Okay. Great. Okay. So today we're going to talk about abusive head trauma. This presentation has many pictures that people might find disturbing. So certainly if there's pictures of anatomic injuries. So please don't hesitate just to turn away or take a break if you find these pictures difficult. It's hard to explain what happens to a child's head when they're abused without actually looking at the various parts of the brain and the head. Abusive head trauma is very common cause of death and disability in children. And children under age 2 are the most vulnerable. And an estimated 2,000 to 3,000 children each year die from child abuse in the USA. And the most frequent cause is head trauma. And I think this is probably highly undercounted because particularly in more rural jurisdictions, lots of times kids don't get autopsies or babies don't get autopsies if they die spontaneously. And many times abusive head trauma will leave no external signs unless you actually do a really good autopsy on the infant. Why are infants so vulnerable? Well, they have no ability to protect themselves. They have very large heads and very weak necks, and they can't tell anyone if they're being harmed. And crying can cause adults to become very angry with infants, but crying is their only mode of communication. And literally every case I've done where the perpetrator has said, what set him or her off, why they started shaking or slamming the baby, was because they couldn't tolerate the crying. They found it so annoying. So I'm going to go through and talk about the various kinds of injuries that we see in children who suffer abusive head trauma. And I think of the head as an onion. We're going to go layer by layer, start at the very outer layer, the scalp, and then go through the left layers of the scalp, and then go to the skull, and then to the fluid or surrounding the brain, and then to the brain itself. So we're going to start with looking at scalp injuries. And one of the things we see is hair pulling. It's very painful. It's very difficult for the child. And what we see, if we see the child acutely, is lots of little red spots where people have jerked hair out of the follicles. And I always, teach my fellows and residents that whenever you're evaluating a child for any kind of abuse, you want to take a very good look at their hair and make sure that you're not finding bald patches that could have been inflicted. Then you also get scalp lacerations and abrasions. This little boy was hit over the head with a canoe paddle, and that's another abusive injury. Now, lots of kids get scalp lacerations when they're playing baseball or doing sports or out running around or have a bad fall. And so these are not, diagnostic of abuse, but it's another type of injury that kids can get. Sometimes this is a child who died, and when we looked at his scalp, we really didn't see anything too unusual. Can you see my pointer? Is that obvious?
Yes. Yes.
Okay. So, but there was this kind of interesting lesion, but when you actually shaved the hair off, here's a very large old scar from being hit over the head, plus new abrasions from being hit recently. So you have to look very carefully on the scalp for lesions. Then there's hemorrhage on the inner scalp. And it always surprises me how a child can look perfectly normal, and yet, and we see no external trauma. And yet when at the autopsy table, when you take the scalp off, you'll find lots of bleeding right under the scalp from blunt trauma, from people hitting the child on the head. And that's so the fact that you can't see any bumps or lumps on a child's head, it doesn't rule out blunt trauma, because blunt trauma can leave lesions on the scalp and under the scalp, on the skull and under the scalp that you can't actually see. And then another type of injury is something that we call subgaleal hemorrhage. That's hemorrhage under the scalp. The scalp is very loose, and particularly if you have a traction injury, if you have a very violent hair pulling, for example, you can break lots of blood vessels and end up with pretty dramatic hemorrhage under the scalp. And just as time goes on, that blood will seep down, and you'll begin to see it over the face and over the neck. But this is from a very serious hair pulling incident. Okay, the skull is next. Whoops, I forgot. Wait. I'm sorry. I have one more that I thought I had, but I guess I don't. I take it back. All right. Well, I'm going to talk just a minute before we go to the skull. I put some slides in, but apparently I pulled up the wrong version of the presentation. But there is a condition that we see in children in the first couple of months of life, where the parents will suddenly find a big lump on their head. And they'll come into the emergency room, and they don't have any history of having an accident or falling or being dropped. And these lumps are not traumatic. They are what we call subaponeurotic effusions of infancy. We don't know how they happen, but if you actually looked at the fluid inside the lump, you'd find that it's cerebrospinal fluid. So the typical story is suddenly the parents realize there's a lump on a child's head, and it's usually within the first month or 2 months of life. And people then think, oh, somebody must have hit the child over the head. But in fact, if you get a CT scan, you'll find that fluid is the same intensity, the same density as a regular cerebrospinal fluid. And so we assume that probably at birth there might be microcrack that develops in the skull, and that fluid leaks out very slowly until it becomes noticeable. So a lump on the head of a little baby is not necessarily from abuse. All right, next we'll talk about the skull. And in infants, the skull is very thin. It's a single layer. In adults, or older kids and adults, it's 2 layers with some material between the 2 layers, and it's much more resilient to cracking. But infants can get skull fractures with really very simple falls. They don't have to fall a long way. And most of these are on the side of the head. We call those linear parietal skull fractures. And these simple linear skull fractures are frequently caused by accidents, not abuse. So, granted, I can't tell you if this child was hit in the side of the head with a rolling pin, or whether he was rolled off the changing table and just hit the floor. But we certainly don't consider simple linear parietal skull fractures in that parietal bone or the side bone of the head to be abusive. As opposed to this child who has this very complex fracture that's very wide and has multiple components to it. This is a much more high energy event and would be much more likely to be caused by someone impacting that child's head with an object. And here's another example of one of these very, very complicated wide skull fractures that we see at autopsy. Another thing we can see is what we call depressed skull fractures, where the skull actually gets pushed in. And this case was really interesting because this was a witnessed event. The child's uncle was angry at the child, picked the baby up and threw them, and he hit the side of a table, of a coffee table, and you can kind of see the imprint of the table on the skull. Now, you can certainly get depressed skull fractures, that's what these are called, from accidents as well. But you want to have a very good explanation. And usually when you see a depressed skull fracture, that means when the child fell, they hit some type of object that caused the forces to be located in one particular area. And here's that same child. You can see where the corner of the coffee table just depressed his little skull. Okay, skull fractures from abuse are more likely to be very wide. We call that diastatic skull fractures, multiple fractures, complex fractures, and sometimes depressed fractures, but not always. You can get depressed fractures accidentally. I had one little girl who was at the zoo with her parents, and she had a ponytail holder that was a rubber band with two plastic balls on it that went around the hair, and then the two balls were hooked onto each other. And she fell from her father's shoulders. She was riding on her dad's shoulders because she was really tired, and she fell from his shoulders onto concrete, and she had two little holes in her skull that were depressed where those two parts of the ponytail holder were. So depressed skull fractures are not always indicative of abuse. Okay, then we're going to go inside the skull. And inside the skull, the first layer is something called the dura mater. And it's this very thick, dense, protective covering that in infants is actually fairly tightly attached to the inside of the skull. And when we talk about bleeding in the head that's around the dura mater, we have two different types. One is called an epidural, and the other is a subdural. And the epidural hematoma is between the skull and the dura, and the subdural hematoma is between the dura and the brain. And they have very different reasons for being there. Most epidural hematomas, the ones right under the skull, are caused by accidents in children and babies. It's really unusual to have a child have an epidural hematoma that has been inflicted. So this is what the dura looks like. It's this very fibrous material that's inside the skull. And into the dura are these large arteries. This is a very large artery that is a part of it's called the middle meningeal artery. But what happens when you get a skull fracture is this artery gets cut, and suddenly you've got arterial blood coming out at a fairly high rate, and very quickly can accumulate and can cause very severe brain injury. What often happens is these are delayed. So a child will maybe fall off a horse or fall from a window, and they'll be just fine. You know, this little artery will get lacerated, but it'll clot quickly, and they'll run around for several hours, and suddenly that clot gets dislodged, and they start pumping blood into their skull, and it can very quickly decompensate from the quantity of blood that's inside that skull. But again, most epidural hemorrhages are not from abuse. So here's an example of a brain. Here is the dura. Here is an epidural hemorrhage outside the dura. And then you have the subdural hemorrhages, which are underneath the dura. And subdural hemorrhages in infants and very young children are much more likely to be associated with an abusive episode than an epidural hemorrhage. So here's the epidural. It has this very funny look on imaging. This is a CT scan. And what you see is, they call this shape lenticular. It looks like shaped like a lentil. And that generally indicates that this is an epidural hemorrhage rather than a subdural hemorrhage. But then you have subdural hematomas or hemorrhages beneath the dura, and those are very concerning for infant abuse. So here's a visual of the dura. It was rolled back, and now you're looking into the brain box, looking to where the brain is held. And underneath the dura is another membrane called the arachnoid membrane, which is a very thin, delicate little membrane. And then between, oops, hang on, this is somehow automatically going forward. Between the dura, I'm sorry, from the arachnoid into the space between the arachnoid and the dura, you get bridging veins, which take the blood that's been used and dumps it into these large vessels, which then carry the blood back to the heart. And these bridging veins are the veins that rupture to cause subdural hematomas. And here's an example in the operating room that you can see here. This is the dura very tightly attached to the skull of an infant. And here's these bridging veins running from the arachnoid, this very delicate membrane on the outside of the brain, up to the draining veins, the sinuses that drain the blood and take it back to the heart. That's what bridging veins look like. So when a child has their head rapidly accelerated and decelerated, their brain will move back and forth in the skull and tear those bridging veins between the brain and the skull, and that leads to subdural hematomas. And this can be from either severe impact, or it can also be from shaking. Another thing that can cause that back and forth of the head on the neck can cause a subdural hematoma. So here's an example of, here's this, what we call the arachnoid membrane. Here's the dura. Here's this large vessel between the layers of the dura, which drains blood. And here is a bridging vein. And so when the brain moves in the skull, you can shear those bridging veins and you end up with a subdural hematoma. So here's an example of one of these at autopsy, or a very large subdural hematoma that we see at autopsy. Okay, and on imaging studies, you can see these. If you imagine, this is the brain. The brain has these fluid-filled cavities called the ventricles, and then there's this area between the arachnoid and the dura that we call the subarachnoid space. And here is one of these big bleeds underneath the dura. And you can see there's blood here and there's blood here. And you can also see that blood is pushing on the brain and compressing the brain, flattening it out, and then flattening the cavity inside the brain that holds the fluid. And this is a very dangerous situation, and this blood needs to be immediately removed by doing surgery. So subdural hematomas. Small subdurals, little subdurals, can be caused by what we call contact injuries or short falls. So if you have a baby that someone drops out of the, say, have the baby or the child in the shopping cart, and the child drops onto the floor at Costco, which is concrete, they will end up often with a very small subdural at the point of impact. And so that is what we call a contact subdural. Excuse me. But when you see extensive bilateral, that is on both sides, subdurals in the midline of the brain and subdurals in the posterior parts of the brain of infants, those are much more likely to be due to abuse rather than to be from an accidental injury. So those are very concerning for abuse, and I'll show you some pictures of those. So here's a midline subdural that goes right down the midline on either side of those collecting vessels. And again, that's not likely to be from an impact injury. Here is a subdural that is found in the posterior portions of the brain, and again, these are not likely to be from minor falls. We see these like in people in high-speed car crashes. So if you have a baby that has this kind of bleeding picture with lots of blood in their head, there has to be a very good explanation for it, or abuse becomes the leading diagnosis. So subdurals are something we take very seriously when we're evaluating infants for head trauma. The next thing, what's below the dura and that little arachnoid membrane we talked about, is the pediatric brain itself. And there's what we call primary brain injuries and secondary brain injuries. And primary brain injuries are injuries that occur at the time of the event, that they occur because of the fact that very high forces have been applied to the head and affect the head. And one of those kinds of lesions is called a contusion or a bruise of the brain. So here's a baby that was badly abused, but you can see that there's these contusions in the brain tissue that have been caused by direct impact of the brain and the head. The other thing we see is something called gray-white matter shearing tears. That's a little harder to explain, but the brain has two different types of tissue. It has gray matter and white matter. And the white matter is much denser than the gray matter. So if you take the brain and you shake it, you've got those tissues moving back and forth at different speeds, basically, because one is very thick and the other is not thick. And the brain separates at the margin of the, I need water, please. The brain separates at the margin of the gray and white matter because those tissues are moving at different speeds. So here's an example of a gray-white matter shearing tear right at the, now here the white matter is toward the center of the brain, the gray matter is toward the outside of the brain, and you can see that here's one of these tears where you actually separate out those two types of tissue and get these shearing tears. And again, these are things we see with very severe accident events. And we also see them in babies who've been shaken, where you actually end up tearing the brain itself inside the skull. Here's another example of those shearing tears on a CAT scan. And that's, again, very concerning for an inflicted injury. Here's a child where the father actually told us that he shook the baby violently. And you can see that large areas of the brain have that shearing that left these cavities between the two types of brain matter. So that's two types of primary brain injury. But the other type of primary brain injury that occurs is something called diffuse traumatic axonal injury. And the nerve cells in the brain have a cell body where the nucleus of the cell is. And then there's these long projections called axons. And the axons go really long distances through the brain, and these presynaptic terminals on the end of the axon hooks up with the dendrites on another cell body to make electrical signals travel through the brain. And these axons are very vulnerable to injury, particularly in infants. In adults, the axons are coated with a material called myelin, and it's almost like insulation on an electrical wire. But the myelin is poorly developed in babies, and so these axons are very vulnerable to shear forces with trauma. So diffuse axonal injury is what causes unconsciousness. So when the axons get stretched, it leads to failure of their function. And there's material that goes down the nerve cells that collects at the point of failure. And in autopsy specimens, we have to use special stains to look for that material that indicates you've had failure of axons. So here, for example, is what we call the cotton wool sign, but these spots on a certain type of, it's called an H&E stain of brain tissue, indicates that there's a point of failure of the axon that from direct trauma to the axon. And diffuse traumatic axonal injury is associated with rotational forces applied to the head. And it's associated with decreased levels of consciousness. And when you think about it, you know, when a boxer hits someone and causes them to lose consciousness, the head will be set in motion. They usually hit them on the side of the head and cause the head to rapidly rotate. And those rotational forces are what causes diffuse axonal injury. So those are the three kinds of primary brain injuries: contusions, gray white matter shearing tears, and traumatic diffuse axonal injuries. But then there are the secondary brain injuries, the things that happen as a result of the accident that are complications, or the accident of the injury, that are complications of the injury. And of course, one is what we call cerebral edema, or brain swelling. The brain will swell, and the brain is caught in a skull, and there's not really no room to move, so that it can only swell so much before the patient dies. So here's a patient with very severe, they've lost their gray-white matter differentiation. That's just a fluid-filled brain with lots of brain swelling. And then what happens if the brain swells beyond a certain point is that the swelling pushes the brain down into the spinal cord, and there's nowhere really for it to go, and so the blood supply gets cut off, and death occurs. So the other thing besides cerebral edema is the kinds of destruction associated with what we call anoxia, or lack of oxygen in the brain. And one of the things we know about abusive head trauma in infants, the outcome is much worse than in accidental head trauma. And I would imagine one of the reasons is that after people abuse a child, they don't immediately pick up the phone and call 911 and start resuscitation. Often they'll put the child down in the crib and leave in anger and come back later to find that the child's in very severe condition. So that anoxia, that lack of oxygen to the brain, is sometimes caused by people not actually immediately getting care for a child after they've injured the child. And then the third thing that happens is toxic chemicals accumulating in the injured brain, so that once you get some parts of the brain injured, various chemicals are released that are toxic to living brain tissue, and so the brain tissue next to the injured tissue will then be injured by this cascade of toxic chemicals that makes the injury more complex. Now, you've probably all heard of shaken baby syndrome, and this is people pick up babies when they're angry, and they violently shake them back and forth 4 or 5 times, and this shaking can cause tremendous brain injury to that infant. And we don't really use the term shaken baby syndrome anymore because it's very difficult when we see a child at the bedside to understand if there was shaking or impact to the child's head or both. And as I pointed out early on, sometimes impact sites that you find at autopsy, you don't actually see when the child's in the intensive care unit. So we prefer to use the term abusive head trauma because it doesn't then imply a particular mechanism. That child could have the injuries sustained from shaking or could have those injuries sustained from impact. So shaking, though, I find in cases where people report that they've shaken a baby, it causes very severe brain damage because it affects all parts of the infant brain. If you hit somebody in the head, you'll get brain damage on the area where the brain was impacted. But if you violently shake a baby, you'll get a very universal injury to the brain, and it's a much worse outcome than an impact injury. The other things that we see when babies are shaken is we sometimes see fractures, we sometimes see injuries to the other parts of the body, but another very important thing that we look at are what we call retinal hemorrhages. The retina is the membrane on the back of the eye that picks up the light signals and turns them into nervous signals that then get transmitted to the brain, so you can perceive that visual experiences. But retinal hemorrhages, retinal hemorrhages are something that we particularly see very bad retinal hemorrhages in babies who have been shaken. But the American Academy of Pediatrics now recommends using the term abusive head trauma because it doesn't imply the mechanism of injury. Although they also say we should continue to educate all parents, new parents, about the dangers of shaking infants and how it can cause terrible brain injuries for the infants. So retinal hemorrhages are not uncommon. You see those in lots of medical conditions and after many types of trauma. For example, if you go climb a mountain and you're at 12,000 feet, when you come down, you'll probably have a few little retinal hemorrhages in the back of your eye. Or if you have a fall and hit your head, again, you could have 2 or 3 small retinal hemorrhages in the back of your eye. But the retinal hemorrhages that we see in babies that are shaken are very, very unusual. And we don't see these in many other types of medical conditions because the retina is made up of multiple layers of tissue. And when a baby is shaken, they get this bleeding in multiple layers of the retina instead of in just the superficial layers. And they're extensive. They go from the very back of the eye out to the front of the eye, out to the what we call the ora serrata, which is the membranous connection right inside the iris, or right outside of the iris. So the entire inner surface of that infant's eye will be markedly affected by hemorrhaging. And here's an example of a photograph of one of a shaken baby and what we see on the eye. And there's hemorrhages in various layers of the retina. And then we see this thing, which is this kind of cup with blood in it. And what happens is with shaking, the retina actually gets split. It gets separated, the layers separate, and then blood accumulates. And these take a long time to heal and can have a marked negative effect on infants' vision. And here's just another example of those too numerous to count retinal hemorrhages in multiple layers of the brain, of the eye, going all the way out to the periphery of the retina. When we see those, there's not many things that cause those. One is shaking a baby. Another is leukemia. And a third is very severe, like hemophilia or coagulation disorders, people that can't clot their blood. But it's easy to diagnose leukemia or coagulation disorders through some fairly simple blood tests. So if we have a baby that has eyes that look like this, and they don't have hemophilia, they don't have coagulation disorders, or they don't have leukemia, about the only other thing left is that they've been a victim of shaking. And here you can see this is an autopsy specimen. And if you imagine the eye has been cut halfway through the middle. Here is the optic nerve that's going to go back to the brain. Here are the retina that lines the inside of the eye. Here's the lens. Here's the pupil. And what we see is these hemorrhages going all the way out to the edge of the retina, not just in the back of the retina, which where we usually see hemorrhages and accidents. The other thing we'll see is the retina will fold. We'll see retinal folds where the whole retina is torn off the back of the eye. So retinal folds, or retinoschisis, which is separation of the layers of the retina, are really something you won't find in normal household accidents. I've seen kids with retinal detachments where the retina actually pulls off the eye and cannot be reattached. We also see hemorrhages in the optic nerve sheath that leads from the eye back to the brain. So here's an example of a child this is an MRI. We just happened to see the retina pulled off. That's the retina that's kind of floating in the eye that has been separated completely from the back of the eye. And here are these hemorrhages in the sheaths of the the optic nerves that lead from the eyes to the brain. And those again are signs of major trauma. So when you have subdural hematomas plus severe extensive retinal hemorrhage with or without gray-white matter shearing tears, diffuse axonal injuries, or other injuries to the body, the most likely diagnosis is going to be child abuse. So if it's a child under 2 and they have those severe hemorrhages and they have subdural hematomas that are similar to the ones we described, that are extensive on both sides, down the middle, that's diagnostic of abuse. So the other thing that happens when you shake a baby is you get subtle changes in the baby's neck. Again, the baby's neck is weak and the spinal cord is not protected. And so that stretching of the spinal cord when the head goes back and forth can actually cause spinal cord damage, and that causes a baby to stop breathing. And once the baby stops breathing, the brain damage becomes really quite extensive. So at the top of the spine and the bottom of the brainstem, where the spine connects to the brain, it's called the craniocervical junction, or C1. It's at the first cervical spine. That's where we'll see subtle injuries in the baby's cord being seen. For example, here's one of those example of one of those bleeds into the spinal cord of an infant that's been shaken. And this is a specimen of a slide and that was taken of the spine at that level, right at the top of the spine. And you can see bleeding within the spinal cord itself, but also you see bleeding in the nerve roots that lead from the spinal cord out into the body. And again, those are very subtle injuries. We often will not see this on imaging studies because these are microscopic injuries rather than large enough that you can actually see on a MRI or a CT scan. Although with the new types of scanners and the new sequences that we've been using, we can now pick up injuries to either the spinal cord itself or the ligaments and the muscles around the neck in babies who've been shaken in about 60% of the cases. So this is the first person who actually described this. A group in Philadelphia, described this type of injury. And they looked at, again, neck injuries in young pediatric homicide victims. They had 41 babies who had died of abusive head trauma, and 71% of them, 29 of those babies, had these really rare cervical cord injuries. And 6 children with abusive head trauma and no evidence of impact to the head, all 6 of those had that primary spinal cord injury. None of the children had spinal fractures, but 6 of the 29, 21%, had ligament and muscle injuries. And 46%, almost half of those babies, who had cervical cord injuries also had injuries to their brainstem, to the very bottom of the brain that hooks up to the spinal cord. So that basically is abusive head trauma. I might say that the outcome of this is very bad. In the kids that get admitted to hospital with abusive head trauma, the babies, about 20% of the babies die, but many of the children who survive this end up with very extensive and debilitating brain damage. And it's very discouraging to see these little guys come back and they're blind and they have cerebral palsy and all kinds of learning disabilities. And sometimes they can't even eat and swallow and have to have a tube to help them breathe, or a tube in their stomach through which they get nutrition. So the outcome is often really very troublesome and totally unnecessary. So teaching people not to shake or hit or slam babies is critically important, because babies are much more vulnerable than older people when it comes to brain injury. Okay, I would take questions if anybody has questions.
We do. Thank you so much. That was excellent. First question I received is, are there ever instances, do you think, like what's the possibility that children could be shaken, have neurons that are shearing and tearing, but not sustain the more significant damage resulting in needing hospitalization? And now they will have lifelong injuries.
Yeah.
You know, how many of these kids could we be seeing out there, really?
Well, the answer is yes, because we know that I can't tell you how many cases where the perpetrator tells me that they've shaken the baby multiple times. And, you know, some people use that to put kids to sleep, because they shake the baby and the baby becomes unconscious or semi-conscious and goes and quiets down. And then they're really surprised when the fourth or fifth time they do it, the baby dies in their arms. We know that when you do this multiple times to a baby, the effect is much worse with each event, because there's something about the first event that primes the brain and makes it more susceptible to injury. But yes, do I think that there's been kids who have severe brain injury, or who are shaken or slammed, and nobody tells anybody about it, and then those kids end up with disabilities, and nobody knows why they have disabilities. I can give you one example of a case I did when we had a child come in for evaluation of seizures, and was showing some very, very troublesome seizures. And what we noticed when the child was evaluated, that the head was very large. And when we did imaging studies, they had large old subdurals that had been there for a while. And when the police did their investigation, the father of the child talked about, you know, the first time he babysat the baby alone, baby wouldn't stop crying, and he got very agitated, and he started bouncing the baby on his knee in hopes that would quiet the baby. And the more he bounced him, the harder he bounced, and he actually started shaking the baby, and the baby had a seizure. And they took the baby to the doctor, or to the hospital, to the local hospital, and did a imaging study, which was read as normal. Well, months later, when we went back and got that imaging study, we found an acute subdural that had been missed by the doctors at the hospital. So this man said, yeah, 3 months ago, I caused this baby to have seizures when I bounced him really hard on my knee. And I never told my wife. And the baby now has a permanent disabilities. So yes, I think this definitely does happen. There's a lot of times abusive head trauma is hard to diagnose. I published a study several years ago where we found that in the children where we actually identified abusive head trauma, 31% had previous episodes of head trauma and had been seen by a doctor and sent home with another diagnosis. One doctor diagnosed anxiety. That's just that baby was anxious because it was the first day at daycare. Or another doctor would say, oh, we think this baby has gastroenteritis. They have flu. They're sick to their stomach, and that's why but when you go back and you put the story together with the imaging studies and sometimes with the actual confessions of the perpetrators, you find that a very high percentage of the kids that we actually identify abusive head trauma in, they've been injured before and nobody recognized it.
Wow. That could really, yeah. Oh. Okay. So the next question, we have different questions coming in different ways here. One is if parents have a baby on their back and they're jogging in one of those jogging carriers where they're carrying the baby while they jog, could that cause brain damage?
Well, I'm not sure, but I would be worried about that because, if the baby can't control their head and their head is flopping back and forth, that's probably not a very good idea. I actually had one case where mom and dad took a very young infant and had him in a bicycle carrier. And they were big mountain bikers. And this is when I was working in Colorado. And they've taken the baby and put the baby in the bicycle carrier. And they went on an incredibly rocky, difficult trail. And when they got to the trailhead, mom and dad both said they had headaches. And the little guy had a seizure. And in fact, he had some bleeding in his head. And I think it was because there was an enormous amount of back and forth and back and forth. So I wouldn't take a baby jogging until they're strong enough that they can hold their head up by themselves and be very stable, which means they have to be probably 4 or 5 months old before they've got that kind of head stability.
Right.
You got to make sure that head is not going to whip back and forth. That's, I think, really important.
Have you seen in your time in this field, have you seen an increase or a decrease in abusive head trauma?
Well, I think I don't know. I think we're doing a better job of recognizing it now. I used to, like when I first went to work in Colorado, they didn't have what they call a medical examiner statute. So if a baby died unexpectedly, the local coroner would sign it out as SIDS, and there would be no autopsy. And one of the reasons was that the local coroners were often undertakers and funeral directors. And if they would say, oh, I think we better get an autopsy on this baby because maybe somebody hurt the baby, then they'd lose business. So by just signing all babies that died suddenly out as SIDS, that was very, very advantageous for them. And so, in fact, right now I'm doing a case of a single individual who killed 3 babies and injured 5 others in different states. And the 3 babies were all signed out as SIDS, even though when you go back and look at the autopsies, they clearly weren't SIDS deaths. So what was the question was, is it getting bigger, worse? I think we're doing a better job of diagnosing it. We're seeing it more. We're recognizing it more. We're teaching doctors to recognize it. And the other thing that I think that's worrisome right now is one thing that we did see during the Great Recession, 10 years ago, when the economy went belly up, we saw a marked increase in abusive head trauma cases because families get stressed, they have financial issues, they're worried, their nerves are frazzled. And of course, we're worried that given our current situation, which is very tense, that we'll start to see more serious head trauma cases just because of the family stress, the stress that families and parents are going under. So I think it's really important to, if you're working with families, to be sure and make sure that if they are at their wits' end, they can get help and not take it out on their babies.
Right, definitely. Another question we have, would it be common or expected for children who do significant repeated head banging under the age of 6 to have subdural injuries?
You know, I don't think so. I don't think that they first, they're not all that strong, and a lot of kids do it, and we just don't see those kids get subdurals. Now, maybe they're getting minor brain damage that we don't recognize, but I think that when you do get these brain injuries, it's very painful, and kids that headbang are doing that to kind of self-stimulate. And I think that my opinion is that if it hurt, if it was really painful, they wouldn't do it. Although who knows? I mean, we don't know, because a lot of kids who headbang have very bad, have underlying neurologic conditions, and that like autistic children, for example. But when you do imaging studies on those kids, you don't see blood inside their head or retinal hemorrhages.
Okay. Someone commented, we researched into bicycle carriers and hiking carriers for our kids. Most of the bicycle carriers are not approved for children under 1 year old, although some do make baby slings. And most hiking carriers also warn that kids should have good head control prior to them going into it. That's good to know, Jen. Thanks for sharing that. Do we have other questions for Dr. Jenny? One of our team members, Lu Yi, asked if abusive head trauma would impact learning. I had responded to her that yes, you know, because it is a traumatic brain, or it's an acquired brain injury, a traumatic brain injury. And Lu Yi, you'd asked, do we know what particular academic areas? I mean, my response to that would be, you would have to work with the school team to determine, you know, what the functional needs are, what the testing shows, interview the parents, talk with the teachers. So you'd have to do an evaluation to really determine that. Dr. Jenny, I don't know if you have anything you want to add.
Well, there have been long-term studies done on outcome, and the thing that I've found is even when babies leave the intensive care unit, you know, they look pretty good, because babies, what do? They poop, they cry, they drink, you know, they suck bottles. And so they'll say, oh, wow, well, you know, this baby turned out just fine, even though he had this terrible abusive head trauma. But then if you follow them over time, they look worse and worse as they're expected to do more things. You know, it's easier to drink a bottle than it is to chew food or learn language or do calculus. So the point is that as time goes on, their deficits appear more dramatic, even in the kids that look pretty good when they left the hospital, because there's more expected of them. And so I would say the chances that a child who's had abusive head trauma, chances that that child's going to be 100% normal or 100% healthy and be able to reach their God-given potential is going to be very slim. There's an interesting person who advocates for children who graduated from Stanford. She's a psychologist, and she was shaken as a baby, and she's blind, and she did have learning disabilities, but you know, she had worked enormously hard and overcame many of the obstacles that she faced. But I still think, you know, life would have been much better for her and easier for her, and she probably would have been able to achieve what she did achieve with much less effort if she had not been shaken as a baby. So yeah. Oh, the other thing that these kids often have when they get into school is tremendous impulse problems and difficulty getting along with other kids. They get aggressive, and they get easily frustrated, and so they have regulatory problems. They can't regulate their mental status because of their brain injury. So I think that these are kids that are going to have to, that should be followed carefully, you know, as they grow up and be given appropriate treatment and for the things that they have encountered, the difficulties they encounter.
Okay, thank you. We have another question. What is your best advice for parents seeking daycare for infants related to staff level of care and training? As a professional in the medical field, oh, go ahead.
Well, I think that the best thing is to be in a daycare that has a policy of never having one-on-one. That a child is always with children are always with at least two adults, because most people don't do these kinds of things if others are watching. The other thing is that I find very helpful is a lot of daycares now will have ongoing video monitoring where the parents can even hook in and watch their kids playing or watch their kids eating lunch. And I think that that's also very helpful. It's interesting because a wonderful group of biomechanics people that study head injuries in children in Louisville, Kentucky, are putting accelerometers, things that measure the forces applied to the head on normal kids in daycares with constant video monitoring, and they're looking at the children that have these falls, the normal toddler falls that all toddlers have, and seeing what types of forces that they're experiencing in their heads, and correlating that with the video data. And what they found is they've been doing this for 2 years, and they've yet to see a child with any type of symptomatic head injury, even kids that fall off jungle gyms, for example. So I think to say that little toddlers get head injuries very easily playing as normal toddlers is not the case. That in fact you need a fairly violent event to cause severe brain damage in a child.
Okay, and the next question. As a professional in the medical field, are infants in daycare centers at risk for injuries to the brain?
Actually, probably much less so than others. There's very, very few. Most kids that get bad brain injuries it occurs when a person is alone with another person. Baby's alone with one person. Most often, I hate to say this, but mom's boyfriend or the father or some relative that's not used to caring for babies and gets easily frustrated. So these types of brain injuries that we see in abused babies, if they happened from some spontaneous medical cause, we would expect to see them occurring in the church nursery or at Walmart or in public or in the doctor's waiting room. But in fact, they almost always happen when a child is alone with a single person. So I think daycare actually is not a high risk place for head injuries for babies. They're probably, if it's an organized daycare with multiple caretakers and good supervision.
Yes. Okay. Do we have any other questions? I'm pulling up my question box. Okay. So if there's no other questions, thank you so much, Dr. Jenny. That was wonderfully informative, and I think that it will help all of us. We're watching, today from Pennsylvania and Colorado, and I think it will help all of us whenever we are working with any student now to really be thinking more in depth about, what might this child have experienced in the past, and it really just open our eyes to, what is happening out there. So with that, thank you so much for joining us today. Everyone, we're done a few minutes early. So thank you for joining our webinars to all of our BrainSTEPS team members. Next year, we will most likely be doing our BrainSTEPS team training via webinars again. And so you will get more information on that, before school starts. So be on the lookout for that. This training will be posted After we get it all closed captioned and everything, you can find it at patent.net and also at brainsteps.net on the homepage. This, the slide handouts will be available on the patent site, and also I will email them out to those who registered. So that's it for today, everybody. Team leaders from Pennsylvania, I'll see you back at our other Zoom link at 2 o'clock. Plan for about an hour or so. And everybody else, have a good summer. Thanks, everybody.